Yeah, I was gonna say, you got out of the gate faster than the gate was ready to go up.
2:33. Okay. Good afternoon. Today is April 23rd, and it is 2:33. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. So managers, we're just convening right now for purposes of approving the first item, which is creation of this committee. Then we'll recess and turn to the committee. So, okay. And I'd also like to announce that in order to make it more accessible to community members, we'll hold the public communication for the Budget and Finance Committee, Executive Committee, and the Board of Managers at a time certain of 5:30. So now we'll proceed to the consent agenda, and we're just going to take up item C1, which is discuss and take appropriate action to approve the creation of an ad hoc philanthropy committee to review and provide board guidance on creation of Central Health philanthropy and fundraising strategies to support the development of non-tax funded revenue generating opportunities to support Central Health strategic priorities and health equity plan and other related activities. Can I have a motion to approve C1? Motion from Manager Valadez, second from Manager May.
Let her be the maker of the motion.
Okay, motion from Manager May, second from Manager Valadez. All in favor?
Aye.
Okay, so that's approved. So we are now going to recess the Board of Managers meeting and turn this over to the Philanthropy Committee meeting.
Okay. So do I need to, since it's my first meeting, do I need to open it up and so forth?
There's a
Okay.
script starting on the first page.
Yeah.
Down
Oh, okay, yeah.
there. Yeah.
Good afternoon, everyone. Today is April the 23rd, 2025, and it is 2:35. So I'm calling there is a quorum present for the committee in attendance, and I would like to call the meeting to order of the Central Health Ad Hoc Philanthropic Committee. As a reminder, one of our committee members may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Let me just ask, I believe we don't have anyone online, so to speak. Okay. He will be.
Later, he can't for this
He may not make this
Oh, I'm
meeting.
sorry, I remember.
Yeah.
But he'll make the other. Okay, we will now receive public comment from the, for the Ad Hoc Philanthropic Committee, but I believe we also do not have anyone lined up. Okay, therefore, let me go ahead and move forward, and just get into the. Oh, okay.
Eagle Eye Chris.
I don't have to read everything again, do I? Okay, all right, okay. So the first item on the agenda is discuss and take appropriate action on the scope of the committee deliverables, including a philanthropic development plan and implementation work plan, procedures, and other activities. We're gonna have the staff make a presentation, but I just wanted to open it up with a few opening comments, and the most important of which is the purpose of the committee. And I basically took the language that we had set up in our agenda posting, but I'll go ahead and just read it again for purposes of the focus of this committee. So the purpose of this committee is to review and provide board guidance on creation of Central Health philanthropy, and we're gonna get tongue-tied on that, philanthropy and fundraising strategies to support the development of non-tax-funded revenue-generating opportunities to support Central Health strategic priorities and health equity plans and other related activities. As we look to sustain and deepen our impact in the years ahead, philanthropy can play a critical role in contemplating public funds and expanding what is possible for our community. This newly created philanthropy committee can help guide this work, ensuring that we are strategic, aligned, and community-driven in how we approach fundraising and partnerships. Today's presentation is meant to ground all of us in the current scope of the committee's work, explore how philanthropy can support the priorities to Central Health in advancing, especially in this time of growth. I will now turn the presentation over to Dr. Lee and his team.
Thank you so much, Chair May, and it's a delight to be here today. I just want to acknowledge the wisdom of creating this committee, Chair Kitchen, so thank you for that. And Chair May, thank you for your engagement and guidance, even in the run-up to today, so we really appreciate that. I know our teams appreciated the opportunity to benefit from your prior experience actually in this area, and yours, Chair Kitchens. We have a few opening thoughts that we've built together with Chair May, but we want to open up for a lot of feedback from the committee, and excited to learn together how this vital committee will complement the work of the overall board, the SPC committee, the Budget, Finance, Infrastructure Committee, and so on. These hopefully will weave together in important ways. And so without further ado, I'm going to hand over to Ted Burton, our Chief Communications Officer, JP Eichmiller, our Vice President Strategy, and Virginia Potter, our Development Director. This may be the first time that you're hearing from Virginia, so hopefully you get to hear a little bit of her background when she has the floor.
Maybe the question is for the staff, but do we have a copy of the presentation in our packet?
Yes, you should. In the Ad hoc Philanthropy Committee packet,
there it is.
the slides should be there. And if anything's missing, we can certainly print. Okay.
Thank you. Just have a lot of
Great.
paper to go through.
So without further ado, team, over to you. Thank you.
Good afternoon, everybody. Ted Burton, Chief Communications Officer, with my colleagues.
Virginia Potter.
JP Eichmiller.
A brief overview of today's agenda. Want to first thank Chair Kitchen and Manager May for meeting with us earlier this week, I believe. Was it earlier this week? To review this and help get this presentation ready for this committee. We are going to first look at some of the factors that are driving the need for a development program, our development evolution, so where we've been, where we are now, where we're going, which includes current state, including the timeliness of some opportunities, talk about future possibilities, and then a timeline for possible deliverables. And as Dr. Lee said, this is a conversation, so we look forward to your input and your suggestions. Next slide, please. So why are we exploring a development program now? Really four main areas to consider. First, an increasing demand for services. You probably know more than anybody here what that means. If you just look at our most recent annual report that I believe we shared with you at the last meeting, there's been a 10% increase year over year of the people that we're serving. A more than 20% increase in the number of uninsured Travis County residents who are covered by our MAP program, and then a more than 12% increase in the number of residents, I think I may have said that wrong, MAP Basic first is a 20% increase, and the MAP program a 12% increase. As you are well aware, there is declining reserve funds, contingency funds are phasing out, and reducing our financial flexibility year in, year out, and that will probably only get more intense. A scaling up of capital projects. We have almost $300 million in capital projects for this fiscal year alone, and there are immense and important opportunities to find funders to help us with future capital projects, and we'll talk about that more. And finally, as everybody in this room and beyond is well aware, there is a decreasing amount of federal funds. Between 60 and 80% of nonprofits that previously received federal grants are now at risk of shortfalls. And I'll highlight a couple or three that we're aware of that are just top of mind from the last few weeks. Next slide. So how do we create greater access to care while juggling increased demand from the community for Central Health services? At a glance, you can see that Central Health, and as you know, is primarily funded on the left of this graphic by local property taxes. And those property taxes are used to improve the health of our community by caring for those who need us most. Those aren't the only sources of fund for Central Health, but those are our primary sources. Other sources include federal dollars and grant dollars. As you know, these funds support whole person care. So not only what's happening inside the clinic, but vitally important, what's happening outside the clinic. Those are the social determinants of care that you all spend a lot of time considering, talking about, and frankly worrying about. So we need to explore other opportunities, other additional resources to meet a growing demand. We're doing what we can possibly do now with the resources that we currently have, but as you know, those resources are limited and they're not enough. We can't partner our way out of this as an institution, and we can't buy our way out of this situation. So the community expects and needs us to step up in bigger and bolder ways. And so you can see what those ways could look like on the top, the sort of lime green or yellow lines showing the opportunity for donations, the opportunities for grant funding, and the opportunities for gifts, perhaps major gifts, to support the mission of Central Health. In the last week, my partner at Austin Public Health called me to alert me that Director Stirrup had done an interview with the Austin American-Statesman, and the Statesman reporter was asking, in light of all the federal cuts, what will Austin Public Health do? And Director Stirrup said they'll look to trusted partners like, and she mentioned Central Health, to see how we might be able to help fill some of those gaps. You heard directly from Walter Moreau just a few weeks ago from Foundation Communities. They are facing significant, potentially devastating cuts to their program, and their budget has been slashed, and they've looked to us to help support. And I know John and others have been working with Walter and Perla to come up with some possible solutions. And then in the headlines just a few days ago, the Central Texas Food Bank is losing $5.5 million in funding for the upcoming fiscal year. Those are dollars that are feeding the patients that we serve. And so if those patients are potentially going hungry, we have to be concerned about that. So the bottom line is the need is growing, and it's only going to grow more, certainly in the next 4 years. And we know the community is looking to Central Health for solutions and support. Next slide, please.
Thanks, Ted. And so these next couple slides you've already seen before. These are about the declining reserve balances for the 7-year plan. And so this just underscores our opportunity now that as those funds are declining in relative to the amount we budgeted for our plan, we have the chance now to look for other revenue streams to help us plan for the future in our current growth. If you go to the next slide, you can see this from a different perspective, and this is the declining reserve balances for cash on hand. Typically, as y'all know, we aim to keep 120 to 150 days of operation cash on hand. Again, just underscoring that you've seen these slides before, but this is one of the key answers to our why now, why us, to ensure that we're taking advantage of our opportunity to really adapt what we're doing from a revenue perspective. And if we go to the next slide, we'll see our reason number 3, capital projects underway. All of you are very well aware of the exciting time it is to be here in this growth and see our projects at Del Valle, at Hancock, at Rosewood, at Colony Park, at the CEC with respite care. And these are just for 2025. I know you've had conversations and thinking about the future, and so there'll be more of those to consider and really have that huge opportunity for us to bring other partners, funding partners alongside us to create impact in our community. And if we go to the next slide, Ted was just talking about this. Another data point is that Urban Institute believes that many of the nonprofits that are affected by the federal cuts will be running at a deficit of 25 to 30%. That's huge. You know the numbers, Austin Public Health, $15 million, Foundation Communities, just to underscore it, was over $2 million for their Health Navigators program, and Central Texas Food Bank is $5.5 million. And so those are just some local examples to really underscore that the time is now for us to be considering how can we step in from a leading partner in our community, and also with thinking about how could philanthropy really play a role. All right. So one of the things that although now that we've told you about our why, we want to make sure we give a little bit of the history of the development activities that we've had along the way. So I'm going to turn it over to my partner, JP.
Thank you. Thank you, Virginia. Yes, as you mentioned, this is not a new thing for us. We've spent several decades building relationships in the community, beyond just with healthcare providers. We've really seen the value over that time of serving as a connector and convener of these various services. If we go back even prior to 2012, many of these projects began, one of them was with the United Way of Greater Austin. We worked with them to provide navigation services through their 211. We also joined a local coalition of healthcare providers, hospitals, Integral Care, Austin ISD to form Children's Optimal Health. That was designed to develop a data and pediatric kind of hub to help improve the health and lives of the children in the community. In 2013, we worked with Shivers Foundation. They developed a Live Strong cancer paper that was specifically addressed towards Central Health to really lay out the landscape and the need of what was going on in relations to cancer care in the community. Fast forward to 2017, the Transit Empowerment Fund, which is a foundation funded by Cap Metro, provided us with a demonstration grant. It was $50,000. That grant was used to create an initial rideshare program. And that seed funding is still being seen and felt today as we've progressed and expanded our transportation services to our MAP and MAP Basic members. In 2018, Central Health underwent an independent performance review, and those findings included recommending that we take on a grants manager and consider a foundation. So building up upon those recommendations, in 2019, we really started to work in our relationship with other regional foundations. This includes St. David's Foundation, working with Connexus, the ICC, making connections at the Michael and Susan Dell Foundation, as well as being introduced to Elena Marks at Episcopal Health Foundation. This was a very important introduction. In 2021, the Episcopal Health Foundation awarded us a $600,000 grant. That was the kickoff to the development of our current strategic plan because they believed in our mission and where we were going to go. In 2022, they gave us another $600,000, and that's where we developed our operational plan. Going forward, we've adopted that plan. The strategic plan also included additionally recommending looking into seeking grant funding, as well as considering a foundation. So where we are now, I'm going to go through a few of these and then hand it back to Ted. So based on those recommendations, in 2024, Central Health hired a grants manager, and over the past year, we've been working with Kim Gavitas to establish the framework for how a grants program could work. We also, last year, received the first check from the Texas State Comptroller for the distribution of the opioid settlement funds. These funds need to be managed in a way that's unique and different to how we've formerly in the past taken in funding through taxpayers. So this has really helped us kind of set up and step up internally how we would manage these type of funds. We have also agreed to act as the administrator for the Permanent Supportive Housing Healthcare Collaborative. This is a group that includes over 20 local organizations involved with improving the state of the homeless in our community, including Integral Care, Community Care, and ECHO. And finally, we have re-engaged with Shivers. We are in the process of working with them on potentially producing another study, regional study into the community health needs related to cancer. And we have also, and this is I think what we referred to earlier as a current new opportunity, have identified a healthcare workforce opportunity being developed by St. David's Foundation, which we're looking forward to discussing further with the board members.
In the past 6 months or 12 months, we also have had exploratory conversations with other hospital districts and ways they have generated revenue outside of perhaps their tax base. Perla and I had conversations with Harris Health, Parkland, and University Health. I think one of the key takeaways is that every hospital district's foundations are different. They don't all look alike. In some cases, the foundations are integrated into the hospital district itself, so the staff actually are employees of the hospital district, like in San Antonio at University Health. In other cases, they are standalone, separate 501c3s with their separate staff. The reporting structures are also different, so and we can talk more in detail about that. You know, the head of the foundation might report into the board chair and the CEO of the hospital district, but they're different. I think Harris Health is an interesting case study. Their 501c was created about 30 years ago, and one way I see it operating is more like the community board of Planned Parenthood, so a larger community-focused board of managers. And just a couple of years ago, they launched the Harris Health Strategic Fund. It's also a 501c3. That was 2023. But this is a smaller board with a real powerhouse board chair, and they are focused on securing, major gifts, so $100 million and above. So two different foundations with two different focuses. And we can talk more about those as well, but there were some really important lessons learned. I think one key takeaway is we don't have to invent the model. If this is the direction that you choose to go in, we don't have to invent the model. I think we would want to borrow the best of hospital districts in Texas and learn from those models and then go from there. And this is a great time to formally introduce Virginia. I know some of you have met her, but I don't think you've heard her backstory and why we feel so fortunate and really honored to have her to join our team. So with that, no pressure, but we'll let you introduce yourself.
Thanks, Ted. It's an honor to be here with y'all today. This is, I think, week 6 for me, so I'm pretty brand new to you, and I'm so excited to be here. I came from the Michael and Susan Dell Foundation, so I was there for 17 years. I started on their educational team because I was a former teacher, so I'd had a background in the corporate space and educational publishing, but I also taught high school at now Navarro High School in Austin. And so that combination really helped me understand from the beginning of how important social determinants of health are to a child's success in life. And so that's always been with me. And as much as I'm proud of all the work that I got to participate in and lead at the foundation, my favorite part was over a decade spending it right here in Central Texas, working across education, health, and workforce. So when the opportunity arose to come partner with you all, it really was about coming home. And so that is why I made the choice to come here and bring any of the experiences, talents, and connections that I can bring to the table to come alongside all of you. All right, so
Welcome.
thank you so much. I'm so happy to be here. So as we discussed, we talked about why. Why are we coming to you now about this development plan and activity and the potential that we have? Well, as much as we are doing fantastic work, we do have some limitations to our structure. So if we go to the next slide, we can see some of the limitations on our healthcare district structure today. We are restricted in the way we use our public funds. We do sometimes have really long processes for procurement and approvals, with reason. The rules make sense. We have limited ability to fundraise. We do have very specific guidelines around our budgeting and spending, again, with reason. If we were to consider other structures that could be in partnership to ours, we could expand the opportunity to use other revenue sources. It allows us, even though we're a fantastic connector right now, we're only working through the partners we have now, but imagine if we had the flexibility to go bigger than that, and we really could take some of these amazing programs and innovations that we work on today to scale. When we think of the ability to act quickly under a different structure, we have that ability. That doesn't mean we don't act with the knowledge of the risk we're taking, or making sure we're in alignment with our priorities, or certainly we want to be transparent about what we're doing. All of those things stay true.
I wanted to weigh in on that one.
please.
So, University Health, their foundation, I thought this was a really powerful and impactful example of the work they do. When the Uvalde school massacre happened, it was the foundation that jumped into action to make sure that families of the victims and the victims themselves had a place to stay and were supported in San Antonio, because all of those victims, the ones that survived, were rushed to San Antonio for care to the trauma center. That's one example. When we had Snowmageddon here, or the power outages that we suffered from, or the pandemic, we as an organization responded in ways that we could, but in some ways it was kind of catch as catch can. Communities that needed water, that needed food, it was our staff that were loading trucks and hauling water and collecting funds. And so I think a foundation would give us a great nimbleness to respond in maybe in bigger ways. And we have a staff that is just chomping at the bit always to do more and do better. And I think it would give them an avenue as well.
Yep, totally, 100%. And when we think about cross-sectoral partnerships, those often don't fit neatly into a public health budget. And so this would be another opportunity where different structures that we could consider would be a way to augment those types of partnerships. Also thinking of amplifying the voice in the work that we do at Central Health. This other structure could partner with us and really complement what we're doing. And then when we think of long-term funding strategies, it gives us, different structures can give us that over decades-long strategy to build reserves in different ways and really be much more flexible than we are today in our current structure. So this would be an accompaniment to us. And so how would we know the right structure, right? So if we look at the next slide, a few of the options, this is not meant to be an exhaustive list, but a few options that we could consider. One is stay the course. We're already seen as a magnificent leader and connector in our community. And although that's phenomenal, and we play off the trust that we've already earned over 2 decades of working here, and it's really minimal cost to keep on that track, we do lose out on the ability to really scale because we have to rely on our partners to do so. We could consider some sort of donor advised fund or a special purpose fund. If we were to do that, we would need some sort of trusted partner in the community, another established foundation to be able to do that with us. That's exciting because it's the administration of that is pretty light. You would only partner with somebody we really trusted, but at the end of the day, you do have limited brand control. And it might feel temporary, and we don't have a lot of ownership over the long-term impact. And then when you look at a standalone foundation, that we would have full control of flexibility, we would have greater agility, but it does have some trade-offs. It has higher startup costs. It does have a governance structure that we would need to pay attention to, and we would need to be careful about what the overlap was between a foundation and ourselves. So how are we going to come to the right conclusion? If we look at some of the considerations that we've been looking at as a team, look, staying in the course as a partner is strong, but it might limit our ability to truly meet the needs of the community in a really flexible way. A donor advised fund could be fantastic, almost as a first step or a pilot of some sorts. It could test the appetite of our presence being a funder and really build some proof points. If we were to move forward to entertain the foundation as a foundation structure, we would want to make sure that we're co-funding alongside our nonprofit, partners and not competing with them. But at the end of the day, we will decide with our community. We will make sure that the answer is guided from input, not only from our community members, other community-based organizations, but business groups, as well as other prospective donors. So how will we actually do this? We only have a few slides left, so you can tell we're getting into the nitty-gritty of what the deliverables and timing might be. So when we look at this, we're aiming to produce a business plan. And so the structure of that plan would have 3 phases. One would be pure planning. One would be this development that leads into potential initial implementation of the structure that we would choose together, and then full implementation and ongoing operations. There's a lot of information on here, but the thing that is most timely is really that phase 1. So that piece around stakeholder engagement, the research and feasibility, making sure we're coordinated with our other committees, budget and finance, and of course infrastructure. All of this work goes very, very hand in hand. Since some of the components of different types of structures would take some time to actually put into place, we can start to explore what are the requirements for these different structures in terms of legal, compliance, reporting. What would the initial plans for fundraising be? How would we staff this? How do we get our other board members excited to join this in this endeavor? And so before we go to the next slide, I'm going to point out that we'll deep dive really quickly into phase 1, but just note at the far right of this slide, I did say that the determined structure really could be operational as early as next year. And so it depends. It depends on how the planning goes. It depends on how you all are feeling about the progress we're making. And so if we go to the next slide, this is really taking a deeper look at the planning phase. And so again, the ultimate question we're answering here with the planning phase is which structure, if any, is appropriate. This is really a go, no-go decision. And so when we look at what stakeholders we would be talking to, I think I mentioned them a little bit ago, be our community members. Those are community-based partners like foundation communities and others. Business groups like our chambers of commerce and funders, whether it's local ones like St. David's, Michael and Susan Dell Foundation, it could be other Episcopal Health Foundation who does still care about Travis County and its surrounding counties. The feasibility study would really need enough data to truly assess how do we know there's enough demand for us to need. I think we have a lot of that evidence already. And how do we weave that in with the stakeholder engagement piece and bring that data and content to the conversation to have them react and say, okay, which messages of our support could resonate? What should we actually be focusing on? Is it expanding access to primary care? Is it our specialty services? Is it a transformational campaign to invite others to come alongside us as we grow the capital investments needed to actually fulfill the needs in our health ecosystem right here in Travis County and the surrounding areas? So again, wanted to underscore the alignment. It is so essential with we're about to be in the height of the budgeting process, so I'm told, and it's a very exciting time. So we want to make sure we're aligned with those other committees on both budget and finance and infrastructure. We will look at the limitations of the types of revenue, non-tax revenue generating structures, and really incorporate all the insights that Ted mentioned earlier from our peer healthcare and hospital districts across the state. And continue those conversations. I just actually was talking to University Health again today and hearing more about their donor engagement strategy. So we would synthesize all of that and come to you all with a plan for recommendation for approval. So if we go to the next slide and look at the timing of that, what we're proposing is to have the plan in draft form and then carried over to the philanthropy committee. We are going to stumble over that, y'all. I want to say philanthropic committee too.
Yeah, me too.
So to present it in November and then get feedback from you all as the philanthropy committee and integrate that into the plan. So over that course of those 4 weeks, finalize it, bring it back to the full board of managers for approval And then for the initial implementation, the plan is in Q1 of fiscal year '26. How can we begin to stand up those structures, begin recruitment in terms of those amazing board members that would be partners to all of us, the legal filings and the fundraising preparations that build on our initial work that you saw us call out in phase 1. And so that's what we have for you today. Thank you for your attention and time. We'd love to answer any questions you have, and we hope you're as excited about this opportunity as we are.
Thank you very much. Discussion? I'd like to hear from our committee, see what questions you might have or thoughts, you know, what kind of perked you up with the presentation. It was very well done, by the way. Very well done. Thank you.
Thank you,
Thank
Manager.
you for your leadership,
Yeah.
you and Chair Kitchen, thank you.
Thank you both.
Cynthia, shall we start with you?
Shannon has.
Oh, sorry, Shannon.
For some reason, the right-hand side of the room always gets attention.
I advocate for the left-handed folks, to be honest.
Mr. Jones, I am very sorry.
You're not the only person. First of all, that was excellent. That was really a great job in terms of framing the discussion we have here. And I would be very supportive of all of those. And I think most of those board members would be because of what you've outlined in terms of the reason. I just have one sort of fundamental question, and I think it's somewhat of a philosophical one. What would, and perhaps it's been addressed by University Health in San Antonio or some of the other hospital districts, but under, what is it, statute 281, as a hospital district, would we be able to still do these types of things consistent with that state statute? And if so, how do we get that message to the community that we're no longer just the Travis County Hospital District? Because voters went to the polls and voted specifically for hospital district. It wasn't, this level of detail obviously wasn't available, and what we're doing wasn't available. So I would think that if we were to do this, and I would be supportive of this type of effort, that we do a very clear job of step-by-step communication as well as the other points that you've talked about. Letting the elected officials know, letting citizens know, letting philanthropic organizations obviously know, helping the community understand the new strategy that we're going to put in place. But I think this is the type of things we're going to have to do if we're going to be able to maintain the necessary revenue to do what we need to do for this. And then my last point is, does this or could this allow us the opportunity to expand beyond just the borders of Travis County, maybe inculcate some of the surrounding counties who have some of the same issues, same concerns, but are not part of our tax base? And if we were to do that, is there the possibility of linking those forces together? So I would incorporate that as part of your planning effort as well.
I have one just response about, I'm a little biased about communications, but I think it always comes down to communications. And so we actually have talked about that, what that communications effort would look like. And at all the other hospital districts, marketing and communications what was a vital piece of how they launched the foundations, helping the community understand why we would need one, just as we've been talking about today, and understand the role of the foundation, and very importantly, as you pointed out, how it's different than the hospital district. So where the overlap is and where it's unique, I believe that it gives the community a chance to dream bigger than perhaps they pay property taxes. They expect us to do our jobs as a hospital district, but I think it gives them a chance to play perhaps a bigger role in envisioning the community they want to live in. So I think it's an exciting opportunity from a communication standpoint, but a difficult one as well.
Thank you for your feedback, Manager Jones. Thank you.
No, you go first, I'll be last.
I was gonna go, yeah, this way.
Yeah, I've already talked
Yeah.
some already about this.
So in thinking about this, I tend to be one of those people who is hesitant to jump in all the way because I don't trust them. There's historically been a problem with transparency. especially when you talk about a private foundation. And so community members or marginalized communities or poverty populations never get a real answer. They're sure as hell not invited to the board meetings where they're having discussions about strategies and priorities and what are we going to accomplish with this set of dollars. And so that, for me, is uppermost in my mind. I've been a part of creating a separate foundation for doing SWAT team work at the legislature, et cetera. But very specific, and it's driven by the boards of the organization, the board members of the organization who say, okay, this is what we need to do, and we go off and do that. So when you have a separate set of directors that's not associated with Central Health, that's not appointed by the city or the county, I'm really concerned about it. With respect to the staff that's going to be supporting this, I'd like to know, where is that money coming from? What is going to be the strain on our staff? Because we have many times listened to, well, our staff is strapped, our staff has got so much to do, blah, blah, out of y'all's mind, out of y'all's mouths at Central Health. And so another whole entity to manage and to drive is going to be a consideration. So I'm concerned about the administrative costs, the operational costs, the staffing costs. Also, I'm concerned about us entering into a relationship whereby someone else is driving us, another entity is driving us. And because I truly believe that we were created this way by 281, thank you, Shannon, because we were here to serve the needs of our poverty populations, not how are we going to fill the buildings that we're buying, okay? We were to provide the services to our poverty populations first. That's number one. And buying a hospital didn't enter into that arrangement, and yet I know that that's a consideration. So I would want to know, why are we having to do this? Is there something that's going on that is not being handled by us at Central Health that we would need to create this entity in order to accomplish that, to resolve that? I need to know all that first, all that evaluation and analysis, so that it's a decision based on data, facts, and that our public knows is they're taking those steps alongside of us. And I guess ultimately, what will their relationship be with respect to determining how those dollars are going to be spent, as opposed to how our tax dollars are being spent? If we're not spending our tax dollars on these particular things, then how is it part of our mission? How is it part of 281 that we have been created to provide services for our population? So that needs to be very, very, just off the top of my head. Those are some of my considerations. And also, I'm also a believer in self-determination. We in the Latino community have oftentimes historically been denied the opportunity to self-determine. And that's the case for all marginalized populations. We've got a great white hope telling us what to do, because that's what society has created for us to do. I don't believe in that. And so are we taking away the opportunities for our could-be construed partner organizations in the marginalized communities to be able to work with their communities to say this is what we need, if we are imposing upon them another entity that's going to take care of them and their needs? Thank you.
Thank you, Manager Valadez. Do you all have any comments or responses with respect to her feedback?
We appreciate the feedback very much, Manager Valdez. I think these are fair questions. Some of them with Manager May's guidance, Chair May's guidance, we started to touch on in this presentation. It's the first cut at this. Part of the why, I think, is, and I don't want to rehash everything, but we're going to need to find other ways to sustain the mission. We want to make sure we do that responsibly, transparently, collaboratively, absolutely. But we're exploring all reasonable avenues, and this is one of those. I think about the work that Harris did. Well, you heard from Ted about some of the emergencies that we responded to. Those are important. And on the other end of the spectrum, LBJ Hospital in Houston was always in the area of greatest need in the city, and had needed a rebuild for a long time. And it was through this whole community capital campaign from the strategic fund. They raised, I think, $2.3 billion for that major upgrade in the access in the most needy area of the city, with all the leading lights, contributing. So we got a lot of work to do to even come close to being doing something like that. But that is in part the aspiration here, and that's partly why we have this committee, to ensure that we are connected to the board and the board's connection to the public.
I appreciate that, but one of the things that draws attention to me, the fact that we have been gentrified out of our neighborhoods. We living in the poverty populations. We have been gentrified. We've been allowed, it was allowed for that. There was a direct plan in 1928, specifically developed to make sure that minority poverty populations got nothing. And that attitude still permeates throughout policies and practices here in the city and the county. Now, we have elected officials that represent various communities and various geographic districts. So that at least has been taken care of. But as you're gentrifying and displacing minority populations, they're no longer in those areas that historically suffered the greatest need because, and purposely so, because they've been they've been forced out due to affordability and lack of response, lack of care, negligence, complicit negligence. And so I want to make sure that we have all the data necessary to show us as board members that what we are doing is not being covered by our budget, and if not, then why is it not being covered by our budget? Because that to me is just as important. If we're creating a different entity to be able to support things that are not being provided by what we were created to support and provide, then we have a problem. I don't know if it's an administrative problem, if it's a judgmental problem, but a policy problem, but that data needs to be provided to us before we start down that road. But it would help us greatly in the development of what strategies to take. Thank you.
If I may respond to you, Manager Valdez, if you look in there, and I have them pass this out, this is, okay, good. That is an attempt to begin to frame what we're gonna be doing and how it's gonna, the idea and the vision is how we want it to kind of play into the other committees that, in this case, would support your questions, i.e. the Budget and Finance Committee. So it's a work in progress, and we're gonna have to figure this out together.
I understand.
Right?
One of the things I did not hear anybody say is equity. They talked about budget and finance, infrastructure, but we have a equity plan that we were supposed to be implementing. And to me, that jumps up to the top. Anyway, thank you.
Yeah, that's right. Yes, ma'am.
Unless, do you want to? One of the things I wanted to say is that, all of these questions and the way you framed it is right on target. I used to work for the Attorney General's office in the Consumer Protection section, in the section that oversaw charitable foundations and charitable trust and wills and stuff. So the way I think about this is it's a tool to extend our buying power. But that only works if we set it up in all the ways that you guys are talking about. In other words, it's not independent. It has to spend money on stuff that we want it to spend money on. We have to have control over who's on that board. It has to follow our purposes, those kinds of things. Now, there are legal parameters about how you have to set it up, but there's a lot of flexibility within those legal parameters, and you guys probably know that. I mean, you said you've been involved, so you guys probably know that. But we have, I think you guys are hearing some of the concerns. I mean, transparency. How do we set this up so that there's transparency? How do we set it up so that those dollars are only spent on things that are within our budget? Various things like that. So I think you've heard at least some of the parameters. There'll be more parameters. I didn't hear all the parameters we want, but that's going to be really important. Yes.
No, I agree with everything everyone has said. I agree, what you said was absolutely correct, Manager Valdez. But this is the very first meeting. And so the tone that we set here helps us to build. We've talked about timelines of November and I forgot what the other
Next
time.
year.
Yeah, I think that what we need to do, I would suggest that we would do, is that we do what you were just saying, is to make sure those things that fall within the parameters of what we're trying to do, the restrictions that will ensure that we do with what Manager Valdez has talked about, that we do not get ourselves caught up in forgetting our mission. Those are the kinds of things that we need to be engaged in now as we plan this, so that when we get to the point of wanting to do this, we have answered those questions.
And it gives you a little bit of a roadmap of what we're looking for.
I heard like several themes, focus. I think this board would be able to determine the focus of a foundation if you decide that go that way. And staffing and structure, it's different in at every hospital district. In Parkland, the CEO of the foundation reports to the CEO of Parkland and the chair of the foundation. University Health, I mentioned, because Manager Valdez, you talked about staffing. Staff, they're employed by the hospital district. The other foundations, they're separate 501c3s, supported by the 501c3. So, and then transparency, and I think Virginia can address the transparency issue because she did this at the Michael and Susan Dale Foundation.
There are different ways that we could do that, and I won't pretend that we always got it right in those 17 years I was there, but there were good examples of where when we were working on the Gulf Coast and we were working with a ton of different types of funders and embedded in the communities, to be able to think about how can we report out transparently in meaningful ways that is in partnership with our community, also ensuring that we have the right board members. We definitely want to be in partnership with them, and also have Manager Valdez, like you said, having the voices of our community present so they can be part of some of the decision making and part of the ingredients of success of whatever this new structure could be.
I think it might be good to capture, I don't know, look to you, Chair, on this, but it might be good to capture the list of parameters that maybe the board could then see, the committee could then see and say, yeah, that's got them all, or no, we didn't think about this, So, and by parameters, I mean the policy parameters. So one of those for me would be governance. Under the heading of governance, I would just me personally would be thinking in terms of the governance structure has to be controlled by Central Health. In other words, and that can mean a variety of different things. Central Health has to appoint a majority of the board members. So you can, that's the best way to ensure, all that has to be done within the law, and y'all have to check into those kind of requirements, and there's differences between public charities and private foundations and stuff like that. But that would be one of the things, and then there's different ways to set it up. You may want to slot those, whatever. But the bottom line is, the bottom line for me is the governance structure would have to be tied back to Central Health, and Central Health's board would have to have control over who's on that. You know, within, you know, a bottom line, otherwise you're gonna get away from,
No, we'll lose it.
yeah, lose it.
We'll lose
And
control of it.
I would say the same thing about, related to governance, is what that I'll call it foundation for lack of, if it's whatever. What they can raise money for and spend money for should be set by the Central Health Board as part of our budget. So I'm saying all these things, not understanding, I haven't researched the law in like, 20 years. But anyway, this, we have to see exactly what's within the law, but that would be my first thinking, for governance, is you'd want to be sure and do that.
If I may, just interestingly, the Harris Health CEO said exactly those things,
Yeah.
Chair Kitchen. So when I got his advice on, he said, it's a great thing. You should really think about it. And when you do, he used the word when, because he's like, you're gonna get there and you're gonna realize how helpful this is. But when you do exactly those things that you mentioned, including the executive director, whatever we call that role, having dual report. We're articulating those kinds of principles in other parts of our system, but he made the exact same points. Those are the fundamentals. So sounds like, and I believe they're not alone. I think UH and even Parkland might be
I'm sure they
structured
all
in
do
similar
something like
ways.
that.
Yes.
You kind of have, you have a, People's Community Clinic, they have a foundation. They're a 501c3 FQHC that has a foundation, and they're tied like that. So I'm sure
That
there's a
might be a
lot.
good model.
Yeah, there's lots of models out there. So,
But since it's a local model, it could be
Yeah.
a good model.
yeah.
Yeah. Me too, I'm dying to hear
Yeah.
from Dr. Brinson.
Yes, I think we would have to lay down very tight rules. And I think that it probably is a good idea to have the staff be employed by us and not the foundation, because that gives us more control and maybe would, help with the transparency.
And it could be more cost-effective
Yes,
right.
to do it that way as well.
yeah,
We don't want to duplicate administrative costs.
right.
That's right.
Now,
Perhaps as part of the follow-up, we could provide a little bit more detail about the different foundations at the hospital districts around Texas. We have a lot of that. We didn't want to overwhelm you today with it, but that might be helpful for you to be able to compare and contrast how other hospital districts are doing it.
Yeah, but I also think it would be helpful to have some discussion once we get
agree.
it from you, because our interpretation may be different. One of the things we also need to remind, and correct me if I'm wrong, is that we have a unique situation with an FQHC as part of our operations. That is not, to my knowledge, the same with these other major districts. So where does that board of directors come into play in terms of especially service delivery when we're adding these other levels? So those are the unique
Yeah.
nuances that we will discover as we go through this discussion. So we're not gonna do this tomorrow,
Yeah.
but these are the kinds of things that
So Dr. Lee, it's kind of like looking at the different layers, which is a little bit of what our conversation was before the meeting. There's different layers to all of this, and it's really critical for us to first lay out what those layers are so that we can get a better handle on how they play together, and then how do we respond? Where are we going to go with that? What decisions will we be making with respect to the creation of all of this? That's kind of how I see it.
Absolutely. Let's
But
say-
I agree with you
Excuse
completely.
me. Yeah, I didn't mean to interrupt. I was just hearing Chair Kitchen's suggestion that we lay out the key parameters. So one we talked about broadly is governance, and there's lots there. A second might be layers, or however we describe how the system really works together and the different boards of directors.
Because remember, you have an
Yeah.
enterprise here.
That's right.
You've got Sendero over there.
That's right.
And you've got CUC.
Yeah.
At some point, we'll probably have to address, or at least, we'll have to address Sendero too. I mean, maybe you address it by saying, you know, we're just not, you know, they're not active with us or something, but we can't totally exclude them out
That's
either.
right. No, I don't think we wanna exclude at all.
We can't be silent is what I want to say about that.
That's
Yeah.
right, that's right. And
Yeah.
Sendero is a good a reference point for us to consider. We have a relationship to Sendero that's very much as Chair Kitchen described and as you described, Vice Chair Brinson. So perhaps that is something to learn from, and it may work in our context. You know, I think we'll lay the options out, clarify the parameters and the questions and the pathway, and all that will go into the plan that hopefully this committee will see in stages and give feedback to. Eventually, when it's ready, this committee will, that's phase one, and then the board, and then beyond. So these are really great, this gives us our direction, I think.
Thank you.
Thank you.
Any more questions, comments?
I have a scoping question. I think I heard you ask it the other day, Cynthia, about giving. You want to say that?
Will we do? Will we, we'll both try to get money, but then will we decide to grant money? How will it only be spent the way we say, or can people come to us and say, I need these volunteers, I need paid employees, are we going to give them the money if we feel that it's appropriate? You know what, we kind of need to work on our scope.
Yeah.
If I might add to this, one of the uniquenesses of being of age, I was in Houston Harris County when the district moved Jefferson Davis Hospital to LBJ. We built it, and one of the things I can remember is back to what you were saying, Cynthia, is the community involvement. There were a lot of folks who were not happy with that because it had been there for years, and even though the communities moved, they didn't. So I guess what I'm saying is that it's going to be critical that we get that community, as you were saying earlier, Ted, get that community involvement from the grassroots level all the way up to the top. So it's not something we can do overnight. I think it's a great idea, but we've got to incorporate all of this.
Very good. Any more additional comments? Let me, yeah, let me recognize, Maram has arrived, and we're still in the philanthropic committee, but would you like to say anything? I know you kind of just walked in.
Well, thank you, and congrats on the new committee, much needed. I think it's necessary, but I also want us to really focus, I think it's a great thing that we're having this committee, that we're vetting through the process. But it also, we want to make sure that it aligns with our mission and priorities. And I think Manager Jones alluded to something, or is it Dr. Brinson, about the funding? Are we also funding? This was something that came up during my pre-meet, a conversation that we had, is that I know, and David chimed in, that we are not a grant funding agency, so we need to think about different ways how we can also give back to the community, so that requires a more deeper dive in understanding what we can and what we cannot do. But the primary focus should be is that what are the resources available? What do we need? What gap would it fill? And do we have also the capacity to take on this additional funding? And so it's not, maybe the funding is there, but we may not be able to fulfill that criteria, whatever the metrics that we need. Because we also have a lot of other things happening at the same time. So we need to balance that. So it's a longer discussion, and I know I read your email that you posted on the message board, something related to the cancer community profile.
Right.
So we can discuss it and a little bit more deeper. But this is a good step moving forward, but we need to think about our mission and alignment. I think that's really critical. What's the need? Don't you all agree?
Absolutely, absolutely.
And because sometimes money is there, But if we don't really need it and we can't deliver on that promise, is it of value to our community? So I am gonna pause here, and again, I apologize for stepping in late, and
All good.
we'll move forward.
Thank you. Appreciate your comments. I think they're well taken. All right, do we have any further comments?
I have some questions.
Okay.
It depends on what whether you wanna do this or now or later.
Well, we're running out of time, so what, we should probably do it now.
20 minutes, yeah. So at the right time, I'd like to hear more details about your plan for engaging with stakeholders. You know, what exactly, because that, I'm thinking that we all might have some input on that. I mean, I know you do that all the time, Ted, but I'm sure that folks may have some thoughts on that. Also, the gathering data on key focus areas, what that data is would be good for us to talk about. Just to make sure we're aligned, that the data that y'all think is important aligns with the data that we're wanting to see. So, that's the only comments I want to make.
Very good, thank you.
And then,
And to some, go
can I
ahead.
make one more comment?
Dr. Burns.
And then I think we're going to have to think through pretty carefully, what if a donation arrives, but they wanted to fund a certain project
Yeah.
that we don't feel is our primary need at the moment? What are we going to do? Are we going to do it because they gave us the money, or there's a lot that, or are we going to turn the money down? All these things are could trip us up.
I know, I'm writing something here. Okay. Oh, I'm sorry, Merle.
And that takes me to the point. What is our mission and alignment of our priorities? Because our intent may be different than someone else's intent, just to put their name or stamp it on the building. So it needs to really align of who we are, what our mission is, what our values are. I think that's really the essence that boils down to, and then those decisions will be easy. I think they'll be like no-brainer. Like, we've discussed it, we know where we stand, that's it. And it may not even come to us, because they know where we stand on certain issues. Do you get it,
Yeah.
where I'm coming? Yes.
Well, I would just be mindful of the fact that this is something that's going to grow over time. Let's monitor what's going on with the demographics of Travis County. In 20 years from now, which is the length of time they took to build the LBJ clinic from the Jefferson Davis, will we be in the same situation in terms of demand for financial resources that we are now? Will the demand for indigent care in Travis County 20 years from now? Or, which is why I raised earlier, should we be considering surrounding counties as part of a mixture of what we go through? I'm not saying we need to do it, but I think we need to consider it, because we know where these populations are moving to,
Yeah.
and they're not moving downtown on Trinity Avenue.
Wait.
So,
Yeah.
I just think we need to be mindful of where we're going to be at the time in which we have, where we're going to be at the time in which we have this new financial model in place. Is what we have these philanthropic organizations in place. Are they going to want to do what we want to do because the population doesn't look like it did when we started it, but it looks a little different now? So all of those are things which we would address, but those are kinds of things we have to think about, and that's why we're starting now the process.
Right. Yes, ma'am.
I think most importantly, where Central Health has been positioned, we need to have governance. So when you're borrowing or a significant amount of money, someone is in control. So we need to establish our governance and our control to allow us to fulfill our authority and our mission, because we don't want to be guided by another entity too. So I think if you
Yeah.
follow me
Oh, yeah.
where I'm going.
Absolutely,
Thanks.
absolutely. Earlier, we had a conversation about it being that we want to make sure that whatever we create, that we have control of it. Yes, yes, indeed. Okay, further, yes,
Sorry, just
Dr. Lee.
briefly, I just want to acknowledge, Manager Jones, the point that you raised twice is actually vital and has been very much in my mind and our mind, and perhaps might even be a fifth reason why, is that the future is long and uncertain, right? And we know there's trends that are happening, and so it may well be that a foundation provides some flexibility to take a broader lens and know in that 20 years from now, folks are probably coming into Travis County who don't reside in Travis County, as they do in Harris County and Dallas County and, Bexar County and so on. If we are successful, folks will come find us, and this may be a mechanism to help provide some of that access and flexibility. So looking to the future is another potential reason why this may make sense. So I just want to make sure I acknowledge, I think that is actually a critical point.
Yes.
So the business plan is a document that'll be recommended by this committee, embedded and all that, to the full board for approval,
Correct.
right? Okay. I imagine that there's also some policies that will have to be adopted, recommended by this committee to the full board. And one that I'm thinking of at the moment is, what's happens in the meantime. In other words, this has a time period. So what is the thinking, and I don't expect you to answer it now, but one of the things that would be good for the full board to hear from this committee is, when does a grant application come to the board for approval? So,
Right.
yeah.
I think these are all the things that we're still trying to,
Okay.
figure out. I mean, we're trying to get this off the ground to begin with.
Okay.
But I think that, let me just be responsive to some of the comments. First of all,
Okay.
I think staff has heard, I hope you all have heard very clearly what this board's comments have been, and more importantly, that you will follow through on addressing those comments in our next board meeting or our next committee meeting, that you come back and be responsive to those. When we first pre-met, that's why I kept talking about a timeline, and I kept saying, this is gonna take longer than what y'all are thinking of, because when we all get our little heads together, we all come up with these wonderful reasons why we need to make sure we flush every detail out. And you can see why. There's big concerns, right? And concerns in a good way, because we want to get started in a positive way, in a very strong position. We don't want to have to come back and, we didn't do this, and now we got to backtrack. We want to get off the ground in a really strong position. So that's going to become critical. So that's why I'm going to just repeat this. We're not in a hurry. I always say that. We're not in a hurry. You may be in a hurry, but we're not. Because ultimately, we'll be the ones who will be responsible for whatever it is that we adopt. So we want to make sure we're methodical, strategic, and methodical with respect to what we're creating. So be mindful of that, and then if you're hearing us that we're wanting, and I had already addressed this, we talked a little bit about that business plan. When I talk about a business plan, I think of something much broader than what we're creating here. And I as I said in my email, Virginia, I don't want to lose sight of that broader product, the broader plan, because everything's going to feed into that plan. Whatever we're doing here is going to feed into your business plan. Whatever we're doing with budgeting, it's going to feed in there, because we talked about needing staff, and where's the staff going to come from, who are they going to work for, how are we going to pay for it, that sort of thing. That all comes out of budget, right? Budget and finance. So that feeds into it too. And then more important, or equally importantly, I should say, when you look at it structurally, what we're trying to create, how does the foundation then support our brick and mortar, if that's what we're talking about doing? And I don't know that we are or not. We're not there yet, but eventually we're going to have that conversation. So that's why I really want us to be very mindful of the big picture as this business plan. Then as you develop the business plan, that that each of these committees feed into their components with that business plan. And then we have, for our purposes of our committee, we have the development component, part of it. So I just want to make that real clear, because I think that's critical for us to get this thing off the ground in the right, strong foundation.
We really
Okay.
appreciate that and agree entirely. I think we're having many aligned conversations that direction. So we will be responsive. We'll bring back, follow up on these issues. I'll borrow a statement one of my special forces friends and colleagues is fond of saying, slow is smooth, smooth is fast, right? So loud and clear. Thank you.
Thank you. Thank you very much. Without, let's see, we're getting close to the witching hour, if we will, for the next meeting. Do we have any further comments from anyone?
Thank you, great meeting.
Well, good. I'm glad you all, and by all means, make sure you email me or let me know if you've got, thoughts and questions about what we need to be addressing, what we need to be focusing, so that we can add it to the agenda or at least consider it as we move forward. I don't think I need a motion for this item, do I? There's no motion being made. So with that, I'm gonna go ahead and, get us, moved into, the closure of this meeting. But before we do that, I do want to say that, while I don't anticipate that this committee will always be meeting, I do think at the very beginning of this, we need to meet monthly. Perhaps in the summer, we might take a little bit of a pause, give you time to do your work. But I do want us to be thinking in terms of, this is another meeting that we've got together with the Board of Managers, and it's part of the whole days or afternoons agenda setting. So please think in that, with that being in mind, for all of those of you that are part of this committee and are obviously, are part of other committees, my thinking is that we can have this meeting the day of the board meeting, try to do it in advance of some of the other meetings. Now, today it worked out fine, but I know that there'll be times when you've got strategic planning. So we'll have to coordinate with you on the time and see how we can work that out so that we're not, getting into your space and yet we can maybe do what we need to do. So we'll figure those things out. So just bear that in mind. So the next meeting would be, May the 28th. On 2025, and while I put 2:30, more than likely that time is gonna change. Okay, so just be aware of that, and we'll figure the exact time out as we go. All right, well then, do I have a motion for adjournment? Since, Manager Valadez moves that we, adjourn, second? And then Manager Jones, does a second on that motion. With that, we, all in favor to adjourn? Aye. Any opposed? Any abstentions? None? Thank you. Our first meeting's completed.
With some time to spare.
Members,
Okay, I'm moving back to my spot.
Just one
Hey,
second.
Cynthia, you can have your spot. I
just
don't like it
want to
here.
make a public
It's too hot.
announcement. We will resume the budget and finance at 4 p.m. Thank you. Yes. I just made it. We'll come back at 4 p.m. for budget and finance. Okay, good afternoon, everyone. Today is April 23rd, 2025, and it is 4:08 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference. Do we have anyone by video? No. Okay, thank you. So we will be managing the audio feeds if any of the participants join. First of all, I would like to announce that, okay, I know for public communication, we typically take it at a time certain at 5:30 p.m. Unless there's someone from the members would like to talk now, specifically on the Budget and Finance Committee, I will be happy to take that. Do we have anyone? Okay, perfect. Okay, so that's it for here, and we will proceed to our committee agenda. Committee agenda item 1, approve the minutes of the March 26, 2025 Budget and Finance Committee meeting. I move that the committee approve the minutes of the March 26, 2025 Budget and Finance Committee meeting. Do I have a second? Second. I have a second by Manager Valadez. All in favor? Oh, any discussions or anything? No, sorry. We don't, okay. Motion passes. Now we are gonna I am gonna take item 2 and 3 together. Item 2, receive the March 2025 financial statements for community health centers. And item 3, receive and discuss an operational update for community care health centers. So we will have Tara Trower, Joy Sloan, and Dr. Yagoda presenting those items. Please proceed and welcome. So, members, I am gonna thank you. Let's have them present because we're gonna have 2 items, and then we will be able to take questions after they present, if that's fine with you all.
Good afternoon, everyone. So we have the March 2025 financial report for community care. If you can go to the next slide. And we are continuing to see the operational challenges that we've discussed for the last couple of months continue. We had about a $1.5 million loss in March. The trends are still along with pharmacy encounters and patient services revenue because of lower Medicaid percentage. We do have a strategy for convenient care with contracted providers that's being executed that will greatly increase access for acute needs and increase revenue. And we're currently working with Central Health to simplify the financial screening process so there's no wrong door for patients, connecting them to care as quickly as we can. Those are great, exciting projects we have on the interim. The reality is we will continue to experience operating losses this fiscal year. Next slide, please. Our balance sheet has not significantly changed from prior months. We were able to collect about $2.4 million on accounts receivable. That was between Central Health and pharmacy provider pay. And so that helped offset operational cash losses. And so we only saw cash decline about $142,000 for the month. We also paid about $1.1 million down on liabilities, what we owe others. And so we haven't seen big changes. Our days on cash on hand did drop to 29 in March. And so we're working closely with Central Health to ensure financial sustainability. The federal political environment remains very unstable. Future grant funding is in question. Current drawdowns are requiring additional justification, so we continue to monitor this very closely, but it is concerning. Next slide, please. And when we look at encounters, we do continue to run under budget this year. We are actively recruiting. We have currently have the contract in place for the services for convenient care. That represents about 4 of our current openings. 3 more are going to be open soon, so getting that transition going will be very, very helpful. We have 10 providers onboarding between now and August to fill current open positions, so that's very exciting. We have an additional 5 positions that are open for which we haven't yet replaced, and we have 4.6 positions related to expansions that haven't been filled yet. Actively recruiting, we are continuing to work very closely with Human Resources to define and develop a provider incentive plan that should really help bring some stabilization to providers. Next slide, please. And so just as a reminder, the big things that we're facing, Medicaid disenrollment, 340B pressures, we're really feeling the Johnson & Johnson prescription assistance program change. It's about $7.5 million per year in lost revenue that started this year, provider turnover. But we are working very closely on ways that we can bridge the gap for this fiscal year. So, yeah, are there questions?
Just Thank you for that presentation, and I don't know what to say. I'm just speechless, what is happening. I can't fathom what is happening. There's no explanation or justification to it. But hopefully, we can intervene and help and assist. And I always want to thank the voters of Travis County and the taxpayers for allowing us to fulfill a gap, a necessary gap. So, members, next month we will be bringing you a budget request to fulfill those gaps. Jeff and I, we've been discussing it. He is going to bring in a plan that is going to be a significant amount. I just want everyone to be cognizant of that, and also in terms of what our plans are in the future. So we need to think of it and think about all our plans, our reserves, so we need to shift the way how we are operating, given what CUC is financially facing. And if I may say, it's more a financial crisis, I want to call it, because it is. So just wanted to let everyone know that we are doing our due diligence to intervene and to help out as much as we can, and to assure our patients that they have sustainable care that is needed. And I'm deeply troubled and sorry. So, does anyone have any questions on this, or should we move forward? Yes, Manager Valdez, and then I'll take Manager Jones.
I don't have a question. I just want to tell you all that I'll support whatever it is you need. That's all. Thank you.
Thank you. Manager Jones?
I don't have a question. I have a comment, though. In light of the fact that we're going to do this, would it not be helpful for us to prepare information for the public of what we're doing, what impact that will have on them, and to make sure that Senator Cornyn and Senator Cruz and other who are not supportive who are supportive of what's happening is aware of it? I mean, can we not be proactive in getting information out so people will be able to say, oh, this is about to happen to me and these people are voting? So I would say in strategy, we might want to look at some way to do that.
Thank you, Manager Jones. That's a really great point. So I know our communication team is here and hear us, and along with our medical team and clinical team and CUC, if we can have some of that information out to the public, because it's going to be a significant amount that we are going to compensate. And that is also going to take away from our other planned projects that we have down the pipeline, because we need to ensure there's sustainability. So I just want to make sure that we have properly communicated to the public, especially our taxpayers, and everyone to realize the magnitude of these decisions that are impacting us locally here. Manager May.
Yes, just to add to, pardon me, to Manager Jones's comment, I think what we should do is make sure that we have a communication plan to our entire congressional delegation to Washington, obviously, which includes Congressman Doggett, and all the other members of Congress that represent our area, as well as obviously Senator, as you suggested, Senator, what's his name? Cornyn. Yeah.
So if I may, actually, this was going to be part of the operational report around the advocacy work that we have been doing since December. It's part of the DNA of being an FQHC, and so we spend a fair amount of time. And so I and Dr. Yagoda and others have traveled to DC to talk about these issues, as well as doing some work locally at the Texas Capitol. And so I'll talk a little bit more about that when we get to the operational report. But thank you, you're absolutely right. And we're very much engaged in that.
Thank you for that. Any further questions before? So this is a good segue for your next presentation.
If we go to the next slide, please. I will segue a bit by stating that I appreciate the concern expressed. We hold the same feelings. we are in some ways fortunate because of our partnership with one another, speaking with CEOs of other health centers who do not have that breadth of, that sort of robust foundation that we have because of the co-applicant model that we work off of. There are health centers that have either had to cut clinics, downsize dramatically, consolidate into other health centers or other health systems. So access to care for vulnerable populations that was imagined through health centers is certainly being marginalized. And so we are very fortunate to have strong partnership between Central Health and Community Care. We look forward to building on how we can maximize the opportunity we have in front of us and take advantage of a moment that is quite severe to come to a more sustainable and promising future. So thank you for your support all along the way. We're going to cover 4 different topics here. Tara has alluded to the advocacy one. She will also go over at the end of this a strategic plan, which is fresh off the presses. You should have a copy, I believe, or it will be passed around shortly. I'll start off by going over some basic demographic data and then addressing a topic that was brought up last time that is center of focus for us, the access and wait times as well. So if we go to the next slide, please. So I'm not going to take for granted that everyone understands what UDS is. It is a Uniform Data Set that is a collection of standard data collected by the federal government for all FQHCs around the country, and it helps us understand at the national level, at the regional level, and comparing one center to another, how we are faring. The data set is built on a set of definitions that have been in place for a long time and are about to undergo a major revision. So this will be the last time we're talking about it. It's just UDS. You'll hear UDS Plus in the future. But it is a calendar year data collection, not a fiscal year. It is preliminarily reported in February, but not finalized until August. So we spend a good portion of our year talking about theoreticals until it's actually blessed and final in the late summer. The full report includes patient demographics and conditions and clinical quality metrics, including the bread and butter preventative screening. It also has some financial data and our cost per patient. Normally, this information is available online, free to the public. Since the new administration's executive orders, interpretations have been made that has to all be pulled down. So you will see the 404 listed on the standard website. We are not able to access that data, which has hampered our collaboration across the whole country in a number of ways. Next slide, please. Here's Community Care's trends. We have seen continued growth in patient volume. Last year saw a 7% increase over the prior year. That is an even faster growth than we had seen in some of the prior years. So we know demand is there and our access is continuing to grow. Importantly, amongst the age demographics, young adult patients are increasing slightly, and that's very promising knowing the demographic shifts of the region. And while the share of pediatric patients has slightly decreased, we know we are able to focus more on this older cohort of that pediatric population. Next slide, please. More patients are self-reporting income, leading to a better picture of what the economic needs of our population. For a long time, there were barriers to reporting, whether it was ones that we introduced through our own technology, or maybe some hesitance on the part of the community based on social pressures. But we are seeing greater and greater reporting, which gives us a greater and greater window into what are the economic needs of our patients. More patients are also self-reporting on ethnicity, and with a higher percentage reporting Hispanic Latino ethnicity. I won't go into the very specifics there, but certainly there for us to peruse. It has not changed substantially over prior years. It still remains our largest demographic. Next slide. Prenatal patient access has been steadily increasing, which is promising. We know that maternal health is a vital focus for healthcare in Texas, and we are encouraged by our being able to provide increasing access to care. You'll see that one broken out by age of the population. Unsheltered patients in all settings, so not just our healthcare for the homeless care teams, our street mobile teams, but also the patients who have historically and regularly used our regular clinics, are reported on the right-hand side. You'll see many, many different definitions of what the spectrum of being unhoused. And so you'll see that that access is also increasing year over year. Next slide, please. The proportions of patients without insurance. So this includes the medical access assistance program. Importantly for UDS, the definition of uninsured means you do not have an insurance program. And because specifically you do not have insurance yourself, and because MAP is not an insurance product itself, so that is included in our uninsured population. So you'll see that year over year, the percentage who are uninsured has been growing steadily. Next slide, please. Now on to access and wait times. I believe Manager May, you had asked at our last meeting for some understanding, and we dug a little bit deeper, and what I'm going to present to you here is the average wait time for a patient in our system. It is about 30 days. The average wait time for a new patient is at 42 days. Notably, we do have same-day access for acute needs in all of our locations, and in particular at our convenient care locations at Hancock and at Southeast Health and Wellness. You'll see all of those metrics broken out by whether they are established with a PCP, whether they're established without a PCP. An example of that would be someone who came in for acute care services and doesn't yet have established primary care, or someone who has seen our specialty care team but has primary care elsewhere, or just plainly a new patient. That is broken out by the different specialties: family medicine, internal medicine, pediatrics, and women's health. If we go to the next slide, please. So those numbers are not satisfactory for us. Let me be clear. That is too long a time to wait. We have an aspiration to more immediate access, and there are a number of different ways that we've been improving that. First, expansions in partnership with Central Health, with new and expanded sites at Pflugerville, Chalmers Court, Del Valley, Hornsby Bend, and the Black Men's Health Clinic. That is physical new footprint. New capacity coming down the pike at Colony Park and at Colony Park and our expanded Hancock Center. We have optimized and standardized scheduling across the system to be more patient-centered. We are also enabling self-scheduling for patients across the system through their patient portals. We are also implementing waitlist systems. We implemented waitlist systems in March that have been exceptionally productive, so that patients have the opportunity to sneak in when there may be a cancellation or a no-show. Second to last, we implemented a dedicated telehealth service line. So this lays on top of the physical footprint we have, creating access for those patients who accept that mode of care for whatever their particular condition are. And notably, that is an increasing proportion of our patients that are interested in that access. And then lastly, as always, augmenting our walk-in capacity. So all of those add up to part of our attempts to bring that wait times down to a more reasonable level. We think even this list is just the beginning of what is a more comprehensive approach as we think through long-term strategies with Central Health about how we approach access. We know that has been discussed among our priorities and key results that we're looking forward to advancing over the fiscal year. I believe that may be the last question, and now I'll hand it over to Tara.
Thank you so much, Dr. Yagoda. So I'm going to talk to you a little bit, as I mentioned, about advocacy. This is something that we have been engaged in as an organization for years and years and years. One of the really fantastic things about being part of this network of federally qualified health centers is the support of the National Association of Community Health Centers, as well as the Texas Association. They organize policy and issues forums, they organize fly-ins, they help us keep apprised of both the financial landscape and those issues that are unique to health centers, and so they've been helping us track, and we've been advocating for increased funding for the health center program, fixes to the 340B program, both at the state and federal level, advocating on behalf of expanded mental health services by allowing other providers at the master's degree level to be billed by Medicaid and thus reimbursable so that they can get their necessary hours for their full licensure and still work in community health centers, an array of other issues. The other way that they have been supporting us, particularly since January, is really helping us keep apprised of this incredibly fast-changing landscape between the executive orders, mergers and restructures of Health and Human Services, really trying to help us keep ahead of and plan for things that we see. A lot of them are not done yet because of the nature of executive orders, but we can see the writing on the wall in some regards, and they are doing the best that they can to help us plan, and we're sharing best practices with other FQHCs around the state and really trying to keep a finger on the pulse of what is happening. We also work very closely with the governmental relations team here at Central Health, who is helping us on the state front, so it's a really great partnership. We have a few pictures here. You'll see your own Rob Borja with us in DC with Representative Lloyd Doggett and the full team, as well as representatives from some of the other health centers. You might see People's Community Clinic there, as well as Lone Star. And then we had a day at the Capitol as well, the Texas legislature meeting with staffers and legislators talking about a wide array of issues and generally educating them about the progress. I will say that as dire as the news may appear, by and large, community health centers do have wide bipartisan support, both in Washington and here in the state of Texas. There may be some pieces and programs that folks may have issues with, and we're certainly going to keep an eye on it. But all the conversations that we had with everyone from Representative Kassar's office to Representative Chip Roy were positive about the fundamentals of the program, and so that is some good news, although there's certainly a lot that we still need to keep an eye on. Next slide. So as Nick mentioned, in terms of our strategic plan, I'm very happy to report that our board last night gave final approval to Community Care's strategic plan. It's one of the requirements of FQHCs that we must do a strategic plan once every 3 years. Of course, for an organization of our complexity of size, that is best practice anyway. But it is a year-long process for us wherein we take in information from our community health needs assessment. We do a environmental scan in which actually some of your executives and team members participated in interviews to help us assess where we've been, where we're going, as well as community partners such as ACC, Austin ISD, and others, and a real leaning in by our board, our teams, to really try and determine what our strategic direction is. This year is a little bit different, and up there you'll see it says 18-month horizon, and that's really in recognition that we are still in the middle of a leadership transition, and we wanted to leave space, and also, since it was a year-long process, this started last January. Some things happened in the fall, but we wanted everyone to be in a good frame of reference and understanding that there might need to be some tweaks once we got permanent leadership at the helm. And so when we think about sort of the overall objective, you see it on the slide up there, that we wish to establish ourselves as the Medical Home Foundation for a patient-centered, value-driven health system for the un- and underinsured in and around Travis County. And in doing so, set a national standard for the vital role of FQHCs in the health systems. I have, and I think will be distributed to all of you. We went to the printers and printed off physical copies for you all. And what you will see is a summary of the plan. Our 5 key priorities, if you will, are health equity. In the previous iteration, it was a little bit broader equity, but really when we think about what we bring in terms of a singular expertise and unique value to our community, it is that ability to look at health through an equitable lens. We also have quality, that we want to be excellent, although our patients do not have many choices in cases we want to be the place that they would choose to go no matter what. Also looking at innovation, which is a change for us. One of the pillars that we have used for the last 3 years was around resourcefulness. Our board, in using that term, really wanted to combine the idea of being good stewards with really pushing the envelope and trying to use that creativity and innovation to solve problems, whether or not it's financial sustainability or access, and applying that continuous improvement philosophy to the work that we do. This time around, particularly given the financial straits that we find ourselves in, the really dynamic forces within the healthcare environment, we wanted to really frame that in terms of innovation straight up, and lots of exciting things, whether it's AI or looking at value-based payment models and other partnerships to really lean into that work to try and figure out how we can do this better, smarter, and more financially effective and efficiently. And then, let's see, I did 4. Last but not least is workforce. I think as you see, and as Dr. Yagoda mentioned, that our provider turnover is very closely tied to the access that we're able to provide, and that's something that we need to be really intentional and solve for. Some of the initiatives here in the strategic plan may look familiar to you. They mirror very strongly some of the OKRs that are part of Central Health's plan. That was another unique factor in this year that we planned more closely than ever before with the team here, particularly Dr. Lee, my counterpart as Chief Strategy Officer, Monica Crowley, and Kim Heineman, to really make sure that we're not creating duplicative work, but really truly aligned work to solve the problems regardless of whether or not it's the scope for Central Health in terms of their responsibility to Travis County and Travis County taxpayers, and then our slightly broader scope in terms of our scope of our service area as approved by HRSA. And so with that, I think I will close out my remarks and open it up to questions on any of the items that we've presented.
Thank you all so much. Appreciate it. Before we proceed, I want to welcome our new board member. Welcome, Mr. Geronimo Rodriguez, to our board. This is your first meeting. Thank you. So, I don't know if you have time, if you're going to, in your board meeting, if you wanted to say anything.
We welcomed him on Saturday also.
But this is the first official board meeting as
Is there
well.
anything you want to say to him?
Speak.
See, now you taught me how to turn it on. No, I appreciate it very much, and as Chair Kitchen mentioned, I was with you all on Saturday as well, so I'm looking forward to this public service.
Thank you. Thanks for being here. I have a couple questions and then I'll open the floor. Going to your advocacy work is great. I hope we can do something locally. I think because we owe it to our taxpayers, so we need to messaging across. I hope that y'all can work with folks here at Central Health, maybe a news piece, something. I want this to go out to our public here, especially our local community. And so that's my piece, and maybe others will chime in as well. Now, one thing that is very disturbing and unacceptable is the wait times. Totally unacceptable. I can't imagine someone ill waiting at least more than 2 months to see a doctor. I personally can't wait. If I call my doctor, I want to see him ASAP. I can't wait if I'm sick, especially within our population. We know they have multiple chronic illnesses, multiple challenges. So I want us to work on improving those numbers and whatever it takes with Central Health, collaboration. So I'm hoping next time you come and present, there's movement and really great movement. It's just not one and date. I want significant movement, because it's unacceptable for our patients. Yeah, that is something, yeah, it's very disturbing on my end. So those are my comments. I know you don't have a magic wand right now, but I am glad that sometimes part of solving a problem is understanding what the problem is. So we acknowledge there is a problem, so we hope that we can solve it. So I'm gonna open the floor with our board members. I see Manager Jones do you have a question?
Yeah, a couple of comments, if I may.
Yes, the floor is yours now.
Thank you for starting on this side, too.
They always start on that side.
First of all, thanks very much for that presentation. A couple of things, and it may not go in order, and I'll make it quickly. On your patient portal, we have seniors of all ages with race and ethnicities who are not technologically inclined. Some of them are board members. So the question I raise is, what are you doing to ensure that they're able to access their information and the like? So that was my first question.
You want me to answer that now, or you want to ask the second one?
No, yeah, answer
Okay,
it.
so great, we have the same concern. And we have designed, not only the platform itself to be as user-friendly as is possible, but we have also equipped community health workers and others to help support enrollment and management or navigation through. So there is some direct support that our patients can get. I will tell you that we have been surprised. We actually have a much higher uptake of remote interaction or remote services, even telehealth, among our more senior population than had previously been anticipated. So while we initially held that concern as well, and we continue to support it, the outcome has been more favorable than we had anticipated. We will continue to keep an eye on that.
And they have access to the technology, the laptops or
Yep, because you can do it through an app on your phone. You can also do it through text messages. So
Right.
things that they are actually, that maybe routine folks may be more familiar with. It's a
Okay.
bit of a choose your own adventure.
For seniors now I'm talking about.
Yeah.
Okay, all right then. Second question is, I agree with what Manager Lasage said about the advocacy, and this is really good, and I think this is very present. But how much have you taken materials and put it out on Springdale Road or on northeast part of town or neighborhood associations or those? Do you all go out and do that kind of campaigning and letting folks know that this is going to impact them? And the degree to impact them is because their elected officials are putting us in this situation. I know you can't be political, but you can be honest. And the question is, do you let them know that reductions may occur because of what's happening in Washington?
So, yeah, so I will be transparent that most of our advocacy, we do advocacy at the local level. It does tend to be with our community partners and with some of the same stakeholders and using Perla and Rob to help with that work. Our team is fairly small. We tend to use our community outreach folks around patient acquisition and really helping around really key healthcare issues like Medicaid, disenrollment, and making folks feel safe given some of the fears around the climate around immigration. We do some advocacy on social media. That tends to be where we can get the best distribution. Locally, I was talking to Dr. Lee earlier, and we have a smaller footprint than Central Health does. And so my role, for example, crosses Ted's and Perla's and a number of others. And so we really partner to try to get the word out as best as we can with the resources that we have. But we'll continue to work on that.
If I may, Manager Jones and Chairman Saitief, our team will work with Tara and team to support and amplify the local message. And it gives me a chance to also compliment Tara. Tara is Ted, Monica, Perla, and now John Morgan all in one person and does an absolutely amazing job, and we will come around to support. So more to come.
Okay, thank you. Any further questions?
I have two more
Yes.
quick questions. One is, do you all take mortality data on your populations?
I wish we had greater mortality data. It is one that we would be very eager to partner with and any of our partners regionally to try and pull that down. A lot of what we have had to rely on historically is actually national data that is locally applied, but we would love to factor that in. It's not a data set that we have access to right now.
Have you worked with APH to get your population's data from a subset of what they have?
We have worked with, we've used the excellent demographic reports they've produced in the past. We haven't gone further than that to see if they have more real-time data. Usually we're responding to comprehensive reports that they submitted.
And the last question is, the Black Men's Health Clinic, in terms of a population, I noticed their numbers are not represented here. Are they included in this wait time? Do you have information on that?
So we didn't break it out to
By clinics.
wait time by clinics for y'all, but their wait times, while initially much briefer because we had a great deal of access, have grown, but they still have more access than many of our other clinics.
They do what, I'm sorry?
They have more access than most of our other clinics.
Okay.
We were able to see that much shorter wait times for patients through the Black Men's Health Clinic.
Thank you.
Okay, thank you. Manager May?
Thank you. Very good information, thank you. You know, under the access strategies, and I think I already know this answer, but I'm gonna ask it and then I'm gonna ask you to expand on it. I'm assuming that you do Saturday clinics as well as after-hour clinics.
Yes.
So I'm wondering, especially for the Saturday clinics, to increase access, would it be appropriate, financially viable for you to consider opening up that clinic even for longer hours?
So to your first question, yes, technically, we have access points on weekends and evenings, not everywhere uniformly. We've targeted those to specific locations, and it is certainly part of our strategy as we look at an expanded access over time to do the analysis on what work we have done and then do some prediction about as we were to expand to maybe more sites that have after-hours access or more sites that have Saturday access, how that might better help meet the need. So there's still some substantial analysis we have to do there.
Okay, thank you.
Thank you. Chair Kitchen, do you have any questions? Dr. Brinson? Manager Valdez?
Yes, thank you very much, and thank you for raising the wait time issue, because that is significant, especially if you're a child, having to wait, you're a mother with a child who has to wait 20 days before they can get seen. And so I'm wondering, since I know you're not in charge of eligibility, Central Health is, I'd like to know whether there has been an analysis as to whether or not, once people have started the eligibility process, how long is it taking them to complete an application to become a MAP or MAP Basic member? I'm just putting this out there, not necessarily for your benefit, but for our benefit.
Well,
and because that will also contribute to a wait time by being able to get seen, especially by the increase in poverty population that we're looking at in our changing demographics.
Thank you for that question. This is actually an area that Nancy Mann, our Chief Operating Officer, has been working very closely with Jonathan Morgan. We both do financial screening. One of the struggles has been that Central Health historically has just screened for MAP, and then if we've got folks who are eligible for other programs, we then have to send them someone else. And so we have been working really, really hard to create a no wrong door, and in fact, we are collaborating and coordinating, and our teams are combining and with a line to me and a line to John to in fact do that better and streamline it throughout the system. It's one of our first deduplication projects that we're working on, and so working very, very intentionally on that, as well as doing virtual financial screenings so people can do it all at once, have everything all together. And so back to that innovation strategy on using the tools at our disposal to really make it easier for our patients to get what they need as quickly as possible. We had a really great presentation just this morning around some of the work that we are doing, that we're able to save up to 100 visits a week, and trying to see if we can get folks scheduled for financial screening on time and get them scheduled for a medical visit. They are much more likely to show up, and hopefully shortens those wait times. And so that's the really holistic way that we're looking at trying to solve the problem, and really excited to do so in collaboration with our colleagues at Central.
I greatly appreciate that, but I'm curious as to whether or not, for the IT people in the world, whether or not there exists a program that you put in this set of data, as I'm an applicant and I'm filling out the screens on the computer, it will automatically pop up, oh, eligible for this, this, and this.
There is capacity to introduce technology and AI
That's
into
what
this.
I'm hoping
And
we will do.
We are all, part of our strategic plan involves substantial investment in AI, and that is, I know, a vision shared by Central Health at large. So we look forward to making this even more streamlined and even more straightforward. If I can speak to just one additional
Yes.
point you mentioned, Manager. The data we presented on access is what we call average lead time. And I'm going to take a risk here getting too technical, but I think it's really important for us to understand from a visceral reaction to those numbers. The average lead time means the average amount of time from the point at which a patient scheduled the appointment to when they actually saw the provider. That may include people who want a visit a month from now. They don't want to be seen tomorrow, but they want to be seen a month from now. It may also include the patient who wants to be seen in 15 minutes. So it is a blend. It is an imperfect measure. We have same-day access. So for that mother who has a child who needs to be seen, they will be seen today. I want to reassure you, there is access for same day. The best metric we have, because of the level of maturity of our system that we felt we could share with you, is what we call the average lead time. And that includes patient choice. So if I'm a diabetic and I want to schedule my appointment in 3 months from now as a routine checkup, that affects average lead time. There is another type of measure that is not yet validated enough in our system, which I commit to bring to you, which looks at what we call the third next available. Why the third? Because the first next available is subject to a lot of volatility when patients cancel or no-show or what have you. And so the industry standard is to use a metric called the third next available, which really represents when is the next time I can get seen reliably. It is also an imperfect measure. We take many of these imperfect measures, and together it forms a portrait of really what access looks like. And I commit to you that we will bring as accurate a portrait of what it looks like. But please rest assured that when it says 42 days for a new patient, that means one thing. For an established patient, they can cut in to be seen today or tomorrow. It just may not be with the provider they want or at the location they want. But we have much more immediate access.
Thank you.
I appreciate that. I just wanted to make one more comment. And that was, historically, there were the few times that I did attend a community care board meeting. It was very, to me, impressive to see the attendance or the lack of attendance in the various locations cited in a reporting corner of the paper that the board members got. And sometimes that helped with determining whether or not we needed to change whatever service was there, or add an additional service, or drop an additional service. And so that also proved to be very important.
Thank you. Thank you, Manager Valdez. Any further questions? Do you have any questions? Okay, great. Well, thank you all. I look forward to our updated presentation, hopefully in the future, near future. So thank you all, appreciate it, and we will see you, Joe, next month. Thank you.
Chairman, I just add one appreciation before we, just wanted to share my appreciation to the team. There've been numerous interactions almost daily, sometimes 3, 4, 5 times in one day, between our various teams, and I just want to lift that up and thank, really the 3 execs you see in front of you are actually interfacing, and sometimes with all of our teams as we put this together, so really appreciate that. I also want to lift up something that I think, if it's okay, Dr. Good, I'll channel some of what you shared with me, that there are new opportunities opening up as we work in this way together. Dr. Yagoda shared with me a perspective that perhaps in times past, if there was Medicaid disenrollment, which substantially affects the revenue and the budget balance for community care, we had a structure in which the risk of that Medicaid disenrollment was held entirely on the community care side. And that meant that there had to be choices made, right, to keep that budget in balance. Now that we are committing, as you indicated, Chairman Saito, to bring back a proposal to share that risk with community care, it opens the opportunity for us to then do things that perhaps we have wanted to do but weren't able to responsibly consider within those separate boxes.
Well,
So,
that's great to know.
from a
Thank
sort
you
of
for that.
risk sharing and also innovative programs perspective, we are excited to work together and look forward to bringing increasingly tailored approaches that really meet our patients' needs. So just wanted to say that thank you to the team.
Thank you all, and sorry, I'm just cutting you short because we're
Thank y'all
running
for hosting
tight
us.
on,
Thank them for hosting us.
Oh, yes, we enjoyed that meeting. Thank you all. Thank you. Now, moving on to item number 4. Receive and discuss instructions for submitting board member recommended fiscal year 2026 emerging priorities. We have, is Monica here? Oh, okay. Is she okay? Okay, great. So we have Monica Crowley, Kim, and, Anissa, Kim and Justine Price will be presenting. So y'all have it 30 minutes. Can you cut it down to 20? Because we're running short on time and we have a full board agenda. And this is, we've already, if you can highlight the updates that have been done to this submission proposal, how different it is from last year, I think that will be very helpful for the team here. Thank you.
Okay, with that, should we get started? Is that
Yes,
okay?
please.
Okay. Managers, thank you again for the opportunity to present on the submission process for the FY26 board member recommended emerging priorities and evaluation framework. Again, my name is Anissa Kendall. I will be sitting in for Monica Crowley today. I am the Senior Director of Strategic Planning, and I will be presenting alongside Kim Heinonen, who's our Chief Transformation Officer, and then Justine Price, who's our Demographics and Statistics Reporting Analyst. We are excited to include Justine in the process this year. She recently joined us from the Williamson County and Cities Health District, and she has a depth of knowledge and experience in developing evaluation frameworks. Just a reminder, along with the driving forces that follows this presentation, these planning exercises are part of the first stages of developing the FY26 strategic priorities and budget, which are adopted by the board annually. Next slide, please. So I'll quickly go through, just want to make sure everyone knows where we are on the timeline. Today is April 23rd, and we are presenting on the submission process for the board recommended priorities, along with the evaluation framework. The board members may begin submitting proposals, and the final date to submit is May 23rd, and that's highlighted in purple on the timeline. On June 11th, we will share the proposed FY26 strategic priorities from the staff, and the subcommittee of the executive team will continue to evaluate the Board of Managers recommended proposals. That is again similar to last year. And then on June 25th, we will come back and present the staff recommendations on the board recommended proposals. On July 23rd, Then we hope to present the final FY26 strategic priorities along with the joint budget with community care. Okay, next slide, please. So again, just a reminder for those that are new, the submission process for the Board of Managers recommended emerging priorities was introduced last year. This was in response to the board's request for a more formal and active role in shaping the proposed strategic priorities. We acknowledge that the board provided feedback on the overall process last year, and just wanted to take a moment, if that's okay, to review the comments, and then opportunities to continue refining that process with you as we move this year. Next slide. So just quickly, we'll highlight, we kind of organized the feedback into two categories. One went well, and then suggested improvements. Thank you again for these suggestions. We did hear you. Overall, from the feedback, it suggested that the approach, the evaluation process, and timeline was well received. We were able to find a good balance between the discussion time and offline review, which made the board meetings and presentation updates more efficient. And we were able to provide continuous updates on the strategic plan and budget activities related to the development of the strategic priorities. Suggested improvements, we are taking action on these suggestions and wanted to share how we are approaching and making progress on them. The check marks indicate where we believe progress has been made, and the circle indicates where there's still work that we could do. So your feedback is important to us. You asked us to start the process earlier. This year, we started socializing the timeline in March. You asked to incorporate retreats as part of the planning process. We've had 3 retreats, including visioning sessions, to date from November, February, and this past weekend with community care. The next bullet speaks to more opportunities to discuss continued development of the future vision of Central Health. We are doing so through regular CEO updates, and then the opportunities for the board to discuss at those visioning sessions. Next, similar to last year, we are also building in presentations with updates on the strategic plan, but we will also include updates on the board-sponsored proposals from last year. You also shared that we should continue incorporating input from community conversations and patients, and that these forums should also shape board proposals. We have been and will continue to use this feedback to address gaps within the system. It is also a shared system priority to conduct patient journey mapping workshops to address this more directly and timely. And then lastly, you asked us to develop a mechanism to convey the Board of Managers proposal ideas earlier. This is a great suggestion. In being mindful of the board meeting time, we will present some options for your consideration. But we are listening, and so thank you again for the feedback, and we appreciate your continued support and input on this process. Next slide. So we'll quickly go through the process for this year. Really is a refresher, but again, staff is available to provide support as you need. Board members will have the opportunity to submit proposals to be considered as part of the FY26 budget, and participation is optional. This year, we are using a more structured format, really to simplify the submission process. And in a moment, Kim will walk us through that form. Please use a separate form for each proposal idea. That way we can parse them out. And if you need additional pages, feel free to use them. Like last year, submit completed proposals to the Board Governance Affairs team via Brianna Yanes. Thank you again, Brianna and team. And similar to last year, a subcommittee of the executives will catalog, review, and then evaluate proposals using the rubric that we'll review shortly. And then as mentioned earlier, the staff will come back in June and present the recommendations to the board for feedback, clarification, and collaborative discussion before we finalize the FY26 budget and priorities. Okay. I'm gonna pause for a second. Okay, Kim, you ready?
Yeah. Thank you, Anissa. So we decided to bring more structure and clarity to the process this year by introducing a standard template for proposals. The template has 4 major sections: the recommendation, the problem it will solve, the analysis, and then expected outcomes. The questions are very similar to last year's, but just reorganized to follow a simple flow, making it easier to understand and evaluate. The first section, you describe what you're trying to accomplish. So top left. The second section, you explain what the problem is that you're trying to solve, linked to system priorities, community needs, or driving forces. The third section is for data-driven analysis. You want to prove the problem that you're trying to solve with numbers, or what might happen if you don't do anything in fiscal 2026. The last section is for expected outcomes. So what does success look like? How do you measure it? Next slide, please.
Thank you, Kim. So similar to last year, we did have a rubric that the executive team used to evaluate proposals, and we're sharing that updated version with you on the screen. We did refine the format to make the criteria and scoring more consistent and transparent. And then the evaluation questions were intentionally reviewed against last year's to provide more of a standardized framework for reviewing all types of proposals. The rubric is organized into 3 sections. The first one evaluates compliance with the statute and legal standards to ensure the work being proposed is within the legal boundaries of Central Health and not putting Central Health at risk. The second is clinical and system alignment. It assesses how well a proposal aligns with a shared system priority, a community need from the strategic plan, driving forces, and to the degree that the proposal improves access, equity, health outcomes, or system-wide and partner collaboration. The last is feasibility and financial sustainability, and this helps us determine whether the proposed work can be efficiently implemented, measured for success over time, and feasible to implement and sustain within available resources and budget. I know that's a lot of information, so we'll just give everyone a minute to review. But we would like your feedback on this as well, and there are weights that are assigned, and we also want your feedback on that as well.
So, do you want us to chime in right now?
Would it be helpful if Justine goes over the rubric scoring, and then we can go
Yeah,
through questions?
let's do that, and then we
Okay,
can.
perfect, okay. Thank you. Justine?
Sure, thank you. Next slide, please. So, the scoring methodology is really intended to be straightforward, open, and transparent, and really as easy and accessible as possible. Next slide, please. Oh, I'm sorry. You got it on the rubric, yes. So the scoring, there are 2 parts that we're going to cover here on these slides. The first part is the example scoring rubric. Each one of these rubrics for scoring is associated with one of those questions that Anissa covered. And you can see going from top to bottom, it's very easy to understand. It starts with that larger category, in this case, feasibility and financial sustainability, followed by the specific question or measure that you're addressing. We've created an easy to use sort of 5-point scoring scale. This tends to be a best practice. It's very intuitive for people to understand. I like to think of it as sort of an Amazon rating or a Google rating. There's no 0, it's just 1 through 5. That makes the math easy as well, and it's paired with objective indicators, so things like minimal, moderate, strong, and that's consistent across the board for the different measures. The description underneath each score there in the center of the rubric helps the scorer understand the points that you're assigning. So it's very clear to see why something is ranked a 2 or why something is ranked a 5, for instance. And then there's an additional box below that's sort of an open-ended box for evidence or rationale to help justify the score, which may be useful in the review process as well. Next slide, please. And so the second part of the rubric is really more of a scorecard where all of the scores that are assigned roll up into a composite score. I like to think of this as sort of a report card where you get a maximum score out of 100. There's no work required here, and that's part of the beauty of it. The scorer just assigns the scores, and the calculations are all done in Excel. But everything is very clear and transparent. All the numbers are here, so there's no doubt as to what the weight was for a particular question or how that converts into a score point, or what the total composite score is. The total score at the bottom right there has a visual color indicator. This can be modified as well, so we'd like to hear your feedback on that too, but you can set thresholds, so it's really easy to see if it's in the high range. In this case, it's green. If it's in the moderate range or the mid-range, it's yellow, and anything below the threshold is red. That can be changed per your liking for issues like accessibility, or if we need additional thresholds beyond just 3. I'll pass it back to Anissa now for next one.
Thank you. Next slide. Okay, so that actually concludes our presentation. The next slide really just covers key dates that we've already covered. In your appendix, we have included supporting documents for your reference. There is the agreed upon shared system priorities. There is a list of the community needs and initiatives as part of the strategic plan. and then the draft driving forces that we'll update once those are finalized. There's also a one-page memo that should have been accompanied, as similar to last year, that outlines the key dates and describes the submission process. So if the PowerPoint is helpful to you, the information is there. If the memo is also helpful to you, that's also another reference document.
Thank you.
Thank you.
Does that conclude your
It does.
presentation? Thank you. I have a couple questions first, if I may. How different is this rubric from last year?
It's not. They're very similar to last year. We kind of just tightened some of the questions so they're clearer. But the rubric is very similar to what we used last year.
We never had access to that rubric, so to me, yeah, I don't think I've ever seen, I haven't.
Correct. We didn't share the rubric last year. It was something that it was the executive team used that to evaluate proposals, but we wanted to share that this year with the team so we could get your feedback.
Well, I'm glad that you did share it because there's several concerns about the rubric. And I'm gonna, so for instance, I'm on this page, the numbering, the weight. Now, what matters, I think, if we're gonna start our program, and we've emphasized it multiple times, sustainability. And to see that sustainability is only weighed 40%, that is a concern, like financially. So I would definitely want to see that number higher. And also in terms of alignment to some of the driving forces, that 20%, I believe it's quite heavy in terms, so if we can lower that number and increase the financial sustainability, because how can we ensure a program or whatever recommendation that we propose to ensure that it's sustainable if we're not financially well balanced? So those are right now my some of my comments. I'm going to open it to my members and we can discuss this further. Chair Kitchen.
Yes, a couple of things. Let me step back for just a minute for our new members. This is the process for board members to submit ideas. I think we have two folks that maybe haven't been through the budget process before. We did this because we wanted to avoid, to the extent possible, we wanted to avoid last minute resolutions and motions to fund X, Y, or Z. So we wanted to put our ideas as board members into a vetting process that's similar or the same vetting process that the whole budget is done with. So not that this is the only, I mean, obviously this is in addition to what all our responsibilities are for understand the budget that comes in front of us. But the other thing to caveat, which we caveated last year and we caveat this year, every single board member has the right as a board member to bring a resolution at any point in this process, even up to, the day we vote. We're just encouraging we encourage all of us to not do that because it's just better for all of us and for our staff if we have vetting time. So, but just understand that that as board members, we cannot tell another board member that they cannot bring something that they wanted voted on. So that's just to set the context for y'all.
Thanks.
So, and then I would just say, I share the thoughts that you had with regard to the weighting. And thank y'all for making this available to us now, because this allows us to comment on that weighting. Because I particularly this year, I mean, it's always important, but I'm particularly concerned this year about feasibility, financial feasibility and sustainability. So I don't know what the right number is, but I would suggest that be weighted a bit higher.
And just to clarify, I think the board has the prerogative to set the weighting here.
Yeah, okay.
It has to add to 100. That's the only
Okay.
constraint, right?
Okay.
And so we'd appreciate the robust discussion. And to your point, Chair Kitchen, this weighting will apply to all of the proposals coming through.
Okay.
There are many, potentially 50 to 100 coming through internally.
Okay.
And they will apply to, so whatever the weighting is will have an influence over everything and how it gets prioritized.
Okay.
That's helpful to know because given right now where we're at financially, and I would definitely recommend a higher weight for all proposals moving forward on the financial risk and sustainability. So, because we just had a presentation earlier on today where we're at financially. So,
What number do you want to propose?
I'll have folks,
Okay.
recommend a number and we can see where we're at. So I definitely, maybe in the past years, 60% for clinical and systems alignment, but right now where we're at financially, that has to be quite higher, significantly higher.
Just for me, I'd do them 50-50, but just to put something on the table for discussion purposes.
Okay, so, all right, do you have any further questions?
No.
So I'm gonna go here, Manager Jones, I'm not gonna forget you, as I promised. So we'll start here.
Because I'm somewhat confused.
Okay,
And so
can you put the mic?
I'm sorry.
So maybe we have further clarity?
These are weighting based upon information that we have shared with you already with regards to our driving forces? Or is this information that basically overall operations?
So
It's not the driving forces.
it's not, so let me, and then you can, so if you recall last year, if you had a recommendation, a proposal for a project that you felt that Central Health should fund or participate in, if you remember that sheet that we had last year, I forgot what your recommendations were.
That's, last year's.
So let's say you wanna you wanna provide free meals to Central Health staff, just throwing it out, just an example. So they will vet that, that's your idea, that's your recommendation. You come forth and complete this sheet. So you will say what your idea is and your reasoning, you'll just complete this form. Central Health will take all that information and apply it to a rubric. And that rubric is here on the scoring. So for each item, so for each of these, they'll have the same rubric and they'll score it from 1 to 5.
I'm following that.
Yeah,
but
so that's what,
But are we building on last year or this year?
we're voting on the rubric, the process
For this year.
for this year.
For this year,
Yeah,
okay.
last year is passed,
Right, so this here is for
for this year,
this year, okay.
correct,
So we will get
yes.
documents.
So so for each project, you'll have to complete a separate form. So let's say you have 3 ideas, you'll complete 3 separate
Right,
forms.
I follow that.
Yes.
Well, I'll get with them when I'm ready to put mine in because
Oh, yes, so we haven't voted on that, but do you have any questions on the weighting
waiting,
here?
no, this makes sense to me, the waiting part. I was just talking about the logistics of doing
Okay,
this.
so so that's really the idea.
Okay.
Manager May,
On the weights.
your speak,
Sorry. On the weights of the 60 and 40%, are those last year's weights?
so we didn't have that accent.
Yeah, so let me clarify, and I should clarify your question earlier. Earlier when you asked if the questions were, so the questions to evaluate the proposals are very similar to last year. The weights are new. We did not have those last year, and so we added them this year really to create more structure and rigor around the evaluation process. It makes it a lot more standardized, so that is different. And that's why we wanted to share this with you this year so that you could give us that feedback and make sure that we're directionally in the right place.
Okay.
Does that help?
So do you have any comments on the weight?
No, I do want to, I want to think through the actual weights, taking what Chair Kitchen said about the 50-50. And I think that's a good starting point, but let me just say, I'd like to see a little more weight on the financial feasibility, financial sustainability. What is the magic number? I don't know.
Okay. Do you have any further comments, Manager May, on that?
No, thank you.
Manager Motwani?
I think The weighting, sort of off the cuff, I mean, didn't strike me as problematic. Chair Kitchen's comment about potentially 50-50ing the weighting also doesn't strike me as problematic. I think if financial stability and feasibility and financial stability would start to cannibalize clinical and system alignment, which, you know, aligns with need, that would become a problem for me. So I think 50-50 I definitely would be fine with, but anything that starts to eat into the one above starts to get problematic because that's mission. Thank you.
Okay. Dr. Brinson? Your mic.
So I think the thing that we could cut back on a little bit is perhaps strengthening partnerships, collaboration. I feel like everything else feels right to me, but we could cut back a little bit. Instead of 15%, like make it 12% or something, 10%. Where would I put that extra points? Well, I guess that would have to be another discussion. We need to.
So we can discuss the numbers. I just wanted to get input. Manager Valadez?
I just want to be clear, I want y'all to clarify to me that when we're talking about, I have no problem with 50-50, so long as I know that the justification for the project that's being recommended is going to eliminate our disparities gaps. So I'm assuming that improvement of access, equity, and care and health somehow or another includes that, but I'd like for it to be very specific. I think the justification for closing the disparities gaps, y'all have provided us the information, maybe you need to provide it again, resend, you know, what we've found as far as medical needs assessments and disparities gaps, or in what populations demographically would be important for us to have. But I want to make sure that that's tied to sustainability and feasibility of the project. Because that has to be some kind of criteria developed for funding the project and for the project actually helping us accomplish our mission.
Okay. Thank you. Manager Rodriguez?
Yes, thank you. I think in general, 50-50 sounds like a good starting point. I think going beyond that, for example, if you flip it 60-40, I think that you'd probably have to add maybe another line item here about the health outcome impact. Like, in other words, if you spend this, then how does that relate to the health outcome? How does it improve it? Because we have to have some rationale for why we're going to move to 60%, and it should be very directly related to our expectation on outcomes or impact that we have for our organization.
So your recommendation to add an additional, I'm just trying to understand.
So I'm not making it, I'm just giving you two different thoughts. Like, one is 50-50 sounds like a great starting point for us as an organization. If we as a board decide we're gonna flip it and, let's say, go 60%
Okay.
feasibility and financial sustainability and 40% clinical and system, then I think there could be a discernment or discussion about adding an additional item that really directly, how does this, I mean, an example, like the question would be like, how does this directly impact our health outcomes? Or how does this directly impact the patient experience, or whatever the right
If we
term
flip,
is.
if we
Yeah,
change those
flip-
numbers, yeah.
If we decide as a board that we're moving to that, that would be a suggested discussion.
That's really a great point. Thank you. So what I'm suggesting, if we can, I think overall seems consensus, we want to do 50-50. Given where we're at for financial stability, I want it to see a higher weight on the financial. So I would really recommend at least 20 to 25, because where we're at this year. Maybe next year we can change the weight, but right now I'm really strongly leaning to 25. And we can go, and I know that Dr. Brinson recommended to the partnership, maybe we can pull up from that percentage and also from the alignment percentage weight, because I think definitely we want to improve access. So if we can shift those numbers, and you can work your magic, but I just wanted to let you know where the emphasis should be. So 25, is that all good with all members?
For feasibility, 25?
Yes.
Um,
So I'm trying to see if we can 25, maybe we can take 5 from here and there. I'm just trying, I don't want to play with the numbers right now shuffling, but I just want, they can bring it back to us.
And if I'm,
Yes.
just a question. If we did, just presume that we did exactly what you just talked about.
Yes.
Here's my question. Dr. Lee, what do you think, how it impacts the work? I'd like your response on that, your thoughts.
Thank you, Manager May and Chairman Satif. I think this has been extremely helpful to hear the input. The thought I'm having is some of the very important points are actually interwoven in more than one area of weighting. So when you think about your point, Manager Valdez, about access and closing the gaps, that's the whole point of the strategic plan, right? And many of the system priorities. And on top of that, we're asking, so in some ways it's sort of double weighting. If you have a strategic plan focused idea that also improves, outcomes and closes the gaps, that's going to score pretty darn well, because you're going to end up getting, so it's both. Similarly, on the feasibility of financial sustainability, operational efficiency, like what we heard about with eligibility or rev cycle, or the many things we deduplicate, is going to hit the bottom line, right? That's going to actually, so there's things here that balance both, and so I would offer that up. And then just listening carefully to feedback, one straw man that we can shoot down is 50-50. And then if you just go down, I'm on this one here, this color. If you imagine it's 20-20-10 and 20-10-20. So basically any factor has either a 10 or a 20% weight. We can see what we're sort of emphasizing, recognizing that some of the key goals are actually balanced across more than one area. And maybe it's easy to understand. No one's saying, oh, one thing is more important than everything else, but it's sort of, there's 20s and there's 10s. So that'd be one straw man. Sure, so this first one, 20%, bring down the new initiatives one from 25 to 20, bring down the partnerships, collaboration 15 to 10. So 20-20-10, bring up the operational efficiency from 15 to 20, and bring up the financial feasibility from 15 to 20. So you just got 20-20-10, 20-10-20. Just a straw man, we can always tweak it, but listening carefully.
I'm fine with that. Are y'all fine with it, members? So is that good for y'all? Okay. So we will move forward with that numbering, that weight that we have. One thing to follow up from last year's recommendation, we would like to have an update on where things are, because I know that board members we all have submitted, I think providing us with a report where our initiatives are, have they worked, where they're at, will be helpful. So if you can provide that at your earliest convenience.
And I probably went through that really fast on the timeline, so that presentation is coming in May.
Okay,
And that will
perfect.
have the update.
Thank you so much. Okay,
Yes, of course.
So, thank you for that presentation. I think we are, and any board members have any questions, we'll get back to you as well. And, just one last thing. That form, would it be on a Word document? How would it be sent, distributed to board members?
That is a great question. It is a fillable PDF, and we will send that out after the board meeting.
Make sure it's easy to use, because last time we had one of those that we all struggled with.
Yes, and we took that feedback and we tried to make it a lot more simpler. So we appreciate your feedback if you have any other suggestions.
Thank you.
Of course.
Okay, thank you.
Staff's available to support, so you don't have to struggle with the form. Just call one of us and we'll
happy to
make
help.
sure.
Okay, thank
yeah.
you all.
Yeah.
Now, I'm gonna move
Thank
on.
you.
Thank you so much, appreciate it. Now moving on to agenda item number 5. Discuss and take appropriate action on oh, yes, Manager Valdez.
Madam Chair, just clarification.
Yes.
I don't think I understood or wrote down, what was that second half, how the score was gonna be weighted? I got 20-20-10, what was this? 2010-20, got it,
Okay, is that good for you?
got it.
Okay, sorry. Now, moving on to agenda number 5, discuss and take appropriate action on a presentation regarding fiscal year 2026 proposed driving forces. Are you ready to do this in open? Or do you want to do it in closed?
I think we can do it in open, and any part of a discussion that, at your discretion, we can put in the closed, but I think, everything that I'm aware of, that we're gonna present. Everything that we have planned to present, I think, is appropriate for open. If the discussion takes us into areas that require closed, that'll be at your discretion, Chair
Okay,
Receptive.
thank you so much. And also, giving the time, if we can just make sure that we can condense it, appreciate it. So, Dr. Lee and Lucas Costello will be presenting.
Wonderful. So just teeing this up, Lucas will kind of walk us through briefly the process of how we incorporated your feedback from last session in between, and then I will walk us through the consolidated slide. Lucas, over to you, sir.
Thank you. Y buenas tardes. My name is Lucas. I'm happy to present here and bring forth the combined driving forces that we were able to pull together with the executive team and this board's input. So just to get us started, next slide, please. So this is just a classic timeline slide just to place us on the continuum of where we are in the budget process. So this presentation and these decisions will feed into what our budget will ultimately shape up to be. So going back here, we'll have today's date, April 23rd, and then going forth later on in June is when we'll start to put these things into practice into our actual budget decisions to bring forth to you all. Next slide. All right. So just to bring us centered, I wanted to focus ourselves on what we talked about 2 weeks ago. So again, this was an exercise that we all did to hopefully enhance what goes into our annual budget and development process. So we took ideas again from not only the board, but also our executive team to fuel what we should be looking at in terms of what those driving forces could be. And those would be summarized as anything that could or should be a focus to us in terms of what our future should shape up to be, right? We did that through a group discussion. We gathered your input, and we will show you an example of what that ended up to be. So next slide, please. This is an example of what the staff proposed. So we categorized everything from our executive team into 4 different buckets. We have since expanded such, but just to summarize what the team came up with, we had the care continuum and partnership opportunities, workforce competition and market conditions, system integration and resource optimization, and finally, economic and regulatory legislative uncertainty. Now, when taking in feedback, next slide, please. We had Post-its going in all different directions. So we took all of the thoughts, we combined them with the staffs, and we were able to pull out common themes. And from that, we were able to synthesize the final buckets, which is what we will present today. Next slide, please.
Lucas, for a second, when did you get those inputs from board?
Those, 2 weeks ago. I think we sent, you weren't present.
Which meeting was it?
It's a special called.
The last meeting we had,
Yeah.
the last.
I think we
AOM
sent
meeting we had.
remotely to, I think both of you all were present. So we sent out for feedback, but we never received a response.
Maybe they didn't get it. Can they go ahead and submit it?
I have a question also. Is this, maybe you can,
Yes.
maybe you can help me.
Jones.
Are these the force drivers
The driving forces, yes.
that we submitted,
Yes, those are the new version, yes.
the new version?
So the prior slide, if you want to go back.
Remember
one
we
more?
did those individual lines?
Yeah, it
and
was
now
the-
they're categorized them
one
under
more
these
back.
categories.
Yeah, we had an exercise in the meeting
Yeah.
where we did the stickies, okay? And then after the meeting, tell me if I got this right, after the meeting, an email was sent out to everybody inviting folks to submit additional thoughts if they wanted to do that. So if they're, I would think that if folks felt like they missed that in some way, there's still an opportunity, to submit.
I
But that's the
understand,
process.
to me, sorry, I was I may have missed that email or whatever it is. This is just, I haven't seen this before. You can proceed, go ahead. Yes,
My
Manager.
question to you is, because I sent a copy, my response to you and to Dr.
That this should have incorporated, I think a
Yes.
lot of what you sent, Shannon, may have been actually submissions for budget ideas that will be part of the process we talked about a minute ago.
Right, but I just think we're changing this as we go through the process. That's the problem, because we were asked to provide budget recommended items as part of that process. And I'm just saying, I don't see them here.
Okay, do you want to?
Sure, and apologize if we were not clear on the process. The goal here was to name the threats and opportunities before us, not necessarily how we would solve for them, but to get a agreed consolidated list in addition to our known strategic plan and our system key priorities and results. What else do we have to solve for in this year's budget? And that's what the driving forces comprise, and that's what we put on the stickies. You had some excellent suggestions, Manager Jones, that I think, to Chair Kitchen's point, are like emerging priority proposals. They're what we would just talk about in the previous section, could each go on one of those submission forms and then go through the rubric process that we just went through. So I think you were just one step ahead of our process in some of your submissions, if that makes sense.
Those have not been lost. I think that
We've
you
got
all,
them, yeah, we've
We
got
are-
them.
you all have them. You all have what Shannon submitted and are putting it into the process, right?
Absolutely, absolutely. So if I may, Chairman Sexton, what I might do is present this slide, and then if there's additional feedback, the board has the discretion not to vote this today and to incorporate additional feedback and vote it next time. And so happy to do that if that makes sense from a sequencing process. Okay, so great. So this is the proposed FY26. Oh, I'm so sorry, Perla. Yeah.
No, I just wanted to reiterate, Manager Jones and I had a phone conversation, and Manager Jones, I'm happy to follow up after this meeting, just to assist in any way we can with the board, the proposals you sent over, but I want you to rest assured that we have those and we're holding on to them until the right time we can help you develop some of those proposals and submit them by the deadline that was presented in the previous
I hear what you're saying. I'm just saying it.
Previous
it
presentation.
Sounds like we're changing the process, or else I heard it differently. I thought that was the expectation was that we would submit those. But we don't have to delay this any longer because it's getting late. But it's a little frustrating.
Well, our apologies. I apologize for the process lack of clarity, and we'll certainly follow up. Okay, so these are the consolidated FY26 priorities. You can see across that horizontal arrow the intent. These are driving forces that may significantly impact, drive, or alter our work and should influence our planning process. Strategic plans cannot know what the future will hold. So this is a way for us to be responsive to a lot of emerging conditions. Actually, this is a year in particular where what we came up with 3 years ago didn't know what would happen this year. You see 5 columns here, and the 5th column is new. Demographic and community infrastructure changes is a new column that incorporates some of the key elements that we heard from the board input at the last meeting. The other 4 columns are the same, though some of the bullet points are modified. So let me take it from left to right. Care continuum and partnership opportunities align on a shared vision and set of priorities with the community, county, and city stakeholders. Explore cancer care. This bullet point relates to the insight that came forward in our demographic report that you may recall, where we are seeing a 70% underdiagnosis of cancer in MapMap Basic compared to Travis County, which itself is seeing about a 30% underdiagnosis compared to the country overall. So cancer is severely underdiagnosed, and this is a flag that we're going to take that insight and we're going to lean in together in multiple ways to understand how we respond. Bullet 3, advance a diverse community workforce development through partnerships and educational program opportunities. This includes working with UT Del Med School, Austin Community College, potentially others. So it's inclusive of a range of health professional development. Going over to category 2, economic, political, legislative uncertainty. A lot in this bucket. Navigating ongoing shifts in the local healthcare market landscape. Evaluating the healthcare hospital district funding, financing, and reimbursement mechanisms. Responding to state and federal administration policy and legislative changes, and the impact of those changes to immigration policies. So just high-level bullet points there. Category 3, system integration and resource optimization. So system alignment, including resource efficiency, strategic priorities and budget planning. A lot of the discussion we had around sustainability and efficiency. Leveraging technology for care coordination and operational improvements, including some of the artificial intelligence opportunities. For us, the A could stand for access, the I could stand for inclusion. And how do we make sure that the right opportunities that are ready for prime time are facilitating eligibility conversations, prior authorization processes, and so on. Bullet 3, strengthen cybersecurity, data management, and continuous monitoring. Keep our data ecosystem safe and effective. Bucket 4, workforce competition and market conditions. There is an ever-increasing competition for experienced talent, we know that. Also affordability of housing, transportation, and child care services, an evolving trend and demographic that Manager Jones is always on point to remind us of. And then healthcare workforce shortages, driving competition. This is again broadly physicians, allied health professionals, medical assistants, and so on. And then this 5th category, demographic and community infrastructure changes, population movement and migration patterns. Also from a demographic report, we actually have now confirmed in the data that there is both dilution and dispersion. There's both new folks moving in and folks moving out. You may remember the orange and blue dots in our demographic report we've confirmed, and that goes out to the outskirts of our county and over the county lines. Bullet 2, increase in homelessness and poverty across demographic groups. And bullet 3, rising housing costs and limited affordability options. So quite a lot under those 5 categories, but this is sort of the consolidated view. Would be grateful for board feedback. And again, at your discretion, Chairman Site, if we could move this for a vote today, or it could be deferred for further input.
Okay. Does that conclude?
That's it.
Thank you so much. So my recommendation, given that we have a new board member and some of our members probably, including like me and probably Manager Jones, have additional questions on this process, I'm going to move the vote for next month. This would also allow us to really look into this, and if we want to edit this or add anything. So I would ask that we move this vote for next month. Now, my ask, I know Brianna is going to be out for a good reason, but if you can circulate an email to all members, and if you, by confirming if a member received or not received, I think that would help us with our votes in the future and ensure that we're not missing any emails. I know we get a flood of emails, so if you can just confirm the receipt of that email. So, members, do you have any questions, or do you want to take this for next month and we can discuss it? Okay, perfect. Okay, so we'll discuss this further for next month, and we'll.
And if we have comments, because I have some changes,
Yeah, we
so I
can-
should send them. We don't have to take the time now. I'm happy to send it in if you
Yeah,
want.
how about this, and then we'll combine those comments and we'll distribute this so every board member has an opportunity to review it before the board meeting. It'll be helpful.
And could we meet with you individually to go over some of these?
Yeah, absolutely. Anissa and I have the time. And also in backup, I have all of the comments that we put on the Post-its written out, so we can go through each one just to confirm or go through any reviews that we may
Okay.
need.
Thank you.
Yep.
And Manager Jones is also, if you have any questions, you can reach out to me or to Pearl, anyone, to make sure that you feel comfortable with this. Okay, are we all good? Okay, thank you all. We'll move on to our final,
Thank you.
no, we have another agenda item, it's not our final one. Hope, we're almost there. Agenda item number 6, receive the March 2025 financial statements for Central Health, including capital projects. And Nikki Riley, Jeff Knodel, and Stephanie McDonald will be presenting.
Hi, Nikki Riley, Deputy CFO.
Stephanie Lee McDonald.
Jeff is right now passing out an updated capital project update from the one that was in your packet. I sent it out late, so I wanted to make everybody a copy. But going over the financial statements first for March, nothing unusual. Taxes are still good. We did make our debt payment on time. We did have some opioid expenses that we reimbursed ourselves for. They represent the first quarter of fiscal year 25, but we actually moved those, approved and moved those expenses in March. It was $614,000. So if you have any questions about that, I can answer that, but it's mostly MAP services, Noxalone, and those were the majority of those expenses. Any
I
question?
forgot to mention a statement before.
Yeah, go ahead.
Sorry, I'm going to read this out to you, board members. So last month, the board requested additional details for the direct service slide, including FTE counts, budgeted FTEs, and encounter data. So unfortunately, the data could not be finalized before today's presentation. So FTE counts by service line will be available next month. And once positions updates are finalized in UKG, encounter data is currently available, but in different grouping than the financial statements. So currently, they're working on aligning the groups to include the financial statements. And I know, Manager Valdez, you have asked for it. Just want to make sure that we covered it. So it will be available next month.
Yes, I have a question.
Yes, Manager May.
What they're presenting is this, what we just got?
No, they're the financials, but this is also updated.
That's the second part.
That's
Further
this
in
is
the
Stephanie's.
backup packet,
This
Manager
is
May?
Stephanie's presentation.
Which is the.
Capital.
Oh, it's this other stuff. Sorry. Yeah. That's the second part, basically.
Yeah, so they're only presenting the financials.
So this is in our packet, that is in our packets.
But we have time to ask questions.
Yes.
One thing I did want to point out is both our direct services and our specialty services from network providers are the percentage year-to-date is a lot higher than last year. If you remember, RZ was delayed last year, and so the percentage of the spend wasn't very high as from budgets in the early months. But now those are on track. Those services are online, and now we're able to provide those services, which is due to us having those clinics open and filling the positions that we need for direct services. Take any questions that you may have on the financials?
So, I believe when was it? We asked, I don't know if it's really, we can discuss this during this item, David, but I know we wanted to have a more policy on expenditures, and especially meals. So
We are working
where are
on
you with
those.
that policy?
We are working on it. It involves us, HR, and right now we have about 3 different documents that we need to gather together. Andy with compliance is helping us do that, but yes, we are working on that.
Okay, and another thing that I think we discussed it over the call, and I see John is in attendance, a process that we would like to have a process or a policy in a way how we contract with vendors. I think the process that you currently have may not be very efficient and equitable, I believe. So just to wrap up, if anyone is seeking funding or to contract with Central Health, from my understanding, this is what was shared. They'll have a conversation with a staff member, and if the staff member deemed that to be appropriate, they'll contract with them.
No.
Is that what I understood?
No, to contract with the vendor, you have to go through procurement, which is procurement is under Jeff. There are there are state laws that have to be followed. And so, no, nobody can contract with Central Health.
What was I think it was related to the funding mechanism. If a entity needed funding, they'll go through that contract to that person. That was what was discussed in the meeting.
That still has to go through approvals.
That wasn't what was shared with me on the meeting.
Okay. Can you state a specific one that you're aware of?
Jeff, you were aware, and Dr. Lee was in the present. I think Dr. Lee is the one who explained that process.
So I think what we're talking about is just any entities that may come forward for additional funding. And so what we're working on is some framework to bring back next month as we look at either funding requests, whether it's related to services that are being provided, funding shortcomings that maybe there was some, as we mentioned about foundation communities, there's some funding that had been provided. There was some question whether federal funding was going to continue. And so what we had talked about was coming back next month and kind of giving a framework to consider some of those requests.
Thank you. So, does anybody have any questions on financials?
I do.
Manager Valdez.
Just to reiterate my concerns in the past, I have raised the question as to whether or not, or the concern, just wanting our staff and Central Health to understand that we will not consider funding duplications. If you have an agency that's getting funded by the state, the county, and Episcopal services, Lutheran services, anybody else, to do the same kind of thing that they're coming to us to fund for, that should not be considered, period. Because then we would be funding a duplicative service. That has been a point of mine, a contention of mine for a long time. And I just wanted to know whether or not we do that. Do we ask, because I specifically brought up a question with respect to foundation communities. Is anybody else paying him or paying them to do enrollments? Is anybody else paying them to do this? And so I just wanted to make sure that we were not duplicating, because first and foremost, I don't like us spending money in that way, because I think it's very ineffective and inefficient. And I just want to make sure that we have
point well taken, Manager Valdez. I think when they come back to us next month, we'll probably integrate it into the policy that we have, into that framework. The same way we have a rubric for our proposals.
Right.
So maybe there'll be something similar to that. So we can discuss it further.
I appreciate it.
When they bring back the framework. Thank you. Okay, thanks so much.
Any other questions about the funding?
Not yet, she hasn't discussed it. No.
Any other, okay.
No, I think we're anxious about this.
Okay. So I'll just go over this sheet real quick, and then Stephanie can answer any questions about the actual projects. But each sheet, the front sheet is a list of all the projects that we're actually working on right now and funding. This is what you usually see each month. The next sheets are those projects, but at a more detailed level. And we are also showing you what the debt proceeds are for that project, how much we've used. And then also, if you notice on Del Valle, we've used all the debt proceeds, and now we're cash financing the rest of it. It is, I believe, most of the invoices have gone through on that project, and so we have $1.9 million left out of the cash financing.
Right, we have not closed out that project yet.
Correct. Hancock Center, it shows the debt proceeds. There is a $115.7 million estimate on the budget. Our debt proceeds are 62.6, so therefore that leaves cash financing of 88.1. And then both, you'll notice on Cameron, we issued debt, the next page on page 4. Cameron, we've issued debt for the 100% of the budget right now. So there's no cash financing currently. And then the next two projects, Colony Park and the CEC, are both cash funded. And you'll see how much we spent on that.
And just as an aside on Colony Park specifically, we have just finished the design document phase and design development phase. We have brought on a construction manager at risk for that project. They are helping us create a revised budget. That initial budget was passed many years ago with a much smaller scope of project. So we will include that in the capital program development for the budget this summer.
Thank you. Manager Jones.
So am I to understand you saying that we were underfunded based upon budgeting several years ago, but we will come back forth to make up the difference?
Correct.
Of what we had.
Through the budget process this summer. Correct.
And any tweaks to the design or anything that will drive those costs, like partnerships or other, that you and I have talked about that might be there?
I think it's the other way. We have 2.28 acres, which sounds like a lot of land, but unfortunately, it doesn't, if you put it flat, hold a lot. So we've had to stack. And so that stacking has also allowed us to put in additional parking that would be needed for, to meet the service and the staff needs on the site. So we are putting in a parking deck that has added some cost to the project, but is the right thing to do to get all of those services up in that kind of vertical structure. And we do have the 3,000 square feet allocated. We are going to, the Austin Public Library has verbally committed that they will do the tenant finish out of that space though. So we will not be finishing it for them, and that will not be included in the project cost.
So that it would be available for use for other purposes?
Right now, it is reserved for Austin Public Library. They have committed that they would like it. They verbally have made a commitment that they would like that space. We are waiting. They will finish it out on their dime. And, should something not materialize with Austin Public Library, or in the future, and there's a public library potentially across the street, we would get that space back and then be able to repurpose it.
But if Austin Library does finish it out and so forth, that would be perceived as a cost savings to us because we're not finishing that out.
I believe it is a partnership opportunity for the community because we would end up with that space back. We probably wouldn't use it for the same purpose as it was built out. We would most likely want to use it for clinical function in the future or some other health-related function. So we just don't know yet. I think it's probably easier to say that we are not using Central Health dollars to finance the public library's mission and their work.
Right, but what I'm trying to get at is, if the public library is going to use a space and they're going to finish it out, that's on their dime, right? So that means that whatever you had, unless you had already projected it out, if you let me ask the question, had you already projected out that the Austin Library or somebody else would be in partnership using that space?
We probably would not have included that space in that building, so we would have saved that additional 3,000 square feet and the cost if they had not been at the table to start.
That was my point, is that you would have saved money. So as a result, let's just presume that they do finish it out. That is still a savings to us, right? To some extent, maybe minimal.
I just want to be careful because Jeff is over here.
Well,
so we
somebody
would not.
answer the question?
We would have not built that. We would not have included 3,000. We would have saved the overall cost by not including that additional 3,000 square feet into this building program.
Okay, but what you had originally budgeted did it include that space?
No, the original budget contemplated a much smaller, about a third of what we have actually now in the budget, and it was done almost 4 years ago, I believe. And so over 4 years ago, and so we didn't know, we didn't have any sense of what, so we put in an amount because we knew we needed to acquire the land, for example, and all of the site costs related. We put in an amount and knew that we would have to come back when that building was, more defined.
So that's an added cost.
Well, that's what I'm trying to say is that, you have a building that, okay, you have a partnership with the city, they're gonna finish out the build out. If they stay, that's fine, great, right? But prior to that, when you were planning the building, you did not plan on that for them, right?
Correct.
So as a result, you had an additional cost.
Correct.
All right, so if they go away, say they decide not to take that build out, and therefore now we've got to build it out. Now we've got an additional cost as a result of that again, right?
Correct.
So that's like a double hit. It's a double hit, and we didn't plan it right.
Well,
Yeah,
but we
to some
did,
extent.
just to start, the program of the clinical space has grown dramatically. We have 8 dental laboratories, I believe, in the plan. We have, room for over 3 providers and some potential growth space on that clinical floor. We have, a commercial kitchen for some of the medically tailored meal programs and other health-related programs that we believe are in our future. These were all things that we did not think about to start at that scale or that size. So the building program, the uses within that building have grown dramatically from when we originally just contemplated a presence as a health and wellness center there. We knew that there was this need in the community, and we wanted to be a good partner with the community. The city will have to pay an operating expense for that space in addition to having those, that tenant improvement cost on their dime. But we would not have put that space into the building program
And I think
to start.
let me just make it clear that I think that everything you've added and that has the potential use for the community benefit is wonderful. That's all well and good. I don't have a problem with that. However, what I'm trying to get us to understand and to see is how, as a result of changing those project details or project orders, we have added costs. And we've got to be mindful of that as we move forward, and our rest of our budget's going to start take a hit from different directions, especially if we're going to expand in other directions as well. So I'm just saying, we really got to be very mindful moving forward on stuff like that.
Colony Park is not the only place what you're talking about has done, so I don't think it's fair to say that this.
No, I'm not trying to point it out just at them, but just overall in general.
Yes, that's just.
So that's a really great point. I don't think did it ever come to us, that expansion? And if I heard you correctly, you said it was a verbal commitment? It was not a written commitment?
We are working on a written commitment.
So
far,
After the plans have been made.
And
is that standard practice?
Well, we have been working with the city of Austin. The city sold us the land, and we've been working with the community and the other community partners, including the other city departments, on this property. Correct me, Manager Jones, how many years have we been working on this? It's been almost, it's at least.
I had hair when we started.
Well, no, Manager Jones, I don't know that you've had hair since I've known you, and that's been for almost 20 years, I feel like.
I'm sure it does.
Okay, so thank you for that. Any further questions?
Just one quick one.
Manager Valdez?
Yes, on the Del Valle Health and Wellness Center, the 2 overages, it looks like professional services and construction. Due to what? Is that still to the problem we had with the contractor?
I think these are, we put a budget together, and remember, we put this budget together during the original budget during COVID. And then we had to come back.
And it was way off.
Right, we had to come back and revise it because of the cost escalations that occurred after COVID.
Right.
I think that these numbers, were our best guesstimate when we adopt when we asked you all and prepared this budget 4 years ago, 4+ years ago. And then, we did put in a contingency, and that is really important for us to have that contingency. If, you look overall, we are under budget, right, or at budget, because we haven't closed the project out. But I think it's important to know that, that we have those contingency funds for a purpose, and that's because we are just making a guesstimate, and frequently with very volatile conditions, and there are some strong headwinds. There were then with COVID, and now I think, as with the tariffs and other conversations. So we want to make sure that we recognize as those contingencies are available in a project because we will need them.
Thank you.
Chairman Sento, if I could offer,
Just 1 second. You said this is the revised budget. In the future, if you can just give us a heads up what we had budgeted, it'll help us.
Oh, this is not the revised budget. This is the original project budget.
But it says revised budget, so that's why.
Up at the top.
Oh, I'm sorry.
That's what was misleading to me.
We did do a revision, right, because I think we prepared originally before or during COVID and had to come back after, as we were getting out of some of the
Would you like to see the original budget as well?
I think it will be helpful for us to see.
Yeah.
I can put that in.
Yeah, so if we can
And
add that.
maybe the date that it was revised, just
Correct.
that you understand this happened
So,
many years
It'll
ago.
be helpful for us.
Sure.
Okay, really quickly, Dr. Lee, because we want to end this meeting, so if you have comment.
sure, just briefly, I want to lift up a point that Nikki Riley was making in calling out debt versus cash finance. So the total scope of the projects you see here that are planned or in process is about 300 million. About 180 million has been debt financed, and about 120 million in total is proposed as cash financed. That plan was made last year before all the headwinds in federal fundings and so on came on the horizon. And so I want to just draw a circle on the 120 million as one of the opportunities for debt issuance that we might take on to improve cash flow and basically spread that out over 30, 40 years potentially, and be able to then provide more support for local partners without necessarily taking that support away from the healthcare equity plan. So just wanted to make sure we saw these are not hypothetical projects. These are ones that we know are well underway. It's 120 million total that we've committed to cash finance, and we could choose to change directions on that with the board's direction and the court's approval. Just want to make sure to make that point.
Thank you for that. I am gonna, thank you for that presentation. I'm gonna end this board meeting, this budget and finance. Agenda item number 7, confirm the next budget and finance committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, May 28th, 2025 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment.
Move to adjourn.
We have a motion to adjourn, a second. Any discussion? I see none. All in favor?
Aye.
Aye. Meeting adjourned. Thank you.
Okay, managers, we had recessed our Board of Managers meeting earlier, so we're going to take it up now. Now, I have a question for you all. We do have food in the other room, right? So we can take a very short break right now, or we can take a break in 45 minutes. Does anybody care? Okay, we're going to take a short break. We are starting again, whether you're here or not, at 6:15. So let's take a short break. You can get food in there.
If you want it, you better go get it.
Okay, managers, we're going to get started again. We're starting back with our Board of Managers meeting. So if we could have folks sit down. Okay. We are picking up with our consent agenda, which is where we recessed. So I'm going to come back to that. So that's okay. So we're picking up on the consent agenda. So we already passed consent agenda item number 1. So we have items 2, 3, and 4. So I move that the board approve consent agenda items C2 through C4. We have a second from Manager May. Yes. All in favor?
Aye.
Aye. That passes. So we'll now proceed to the regular agenda. Managers, we did not have anyone signed up for
Public communication.
yeah. So we'll proceed now to the regular agenda. The first item for us is to receive and discuss a report from the President and CEO. If you all will remember, this is the report that Dr. Lee has been preparing for us. I think this may be the second or third time, something like that. Fourth time. Oh, thank you. Fourth time. So he has he's prepared an order in which he's reporting things to us, and we'll deliver this in 15 minutes.
Or less.
Or less.
Thank you, Chair Kitchen.
Thank you.
So managers, as per some of the feedback, there is both a verbal component and a backup component. So I won't speak to all the backup components, but I'll speak to parts of them. The priorities and key results are going to be presented shortly as the next agenda item. Going to the leading edge, this focuses on new services, innovations, and partnerships, things that are now sort of happening, but just rolling out. These include work with the Parsons House in Austin. This is a new collaboration that really looks at offering a lifeline for unhoused older adults in Travis County. This is the first of its kind partnership in Texas with vulnerable patients enrolled in the Central Health MAP and MAP Basic program who are able to receive temporary housing and wraparound support in a safe, welcoming environment, which is a crucial step toward recovery, long-term independence. Another piece of good news, we have Medicare approval status. So thank you to all of you and to many of the team members. Medicaid is up next. And there may be a couple folks who we're going to be approaching just to make sure we have all the paperwork in order, but really appreciate all of your assistance with that. Turning to clinical programs, we have ear, nose, and throat services. This was a service that was a little bit later in our order of rollout in our healthcare equity plan, but an urgent need from our community, one of the highest sort of in-demand needs. And this is an example of when the right stars align, we move on it. So Dr. Kevin Robinson is an African-American man who is fluent in Spanish and completely dedicated to our mission and a very qualified ENT surgeon. So he is now seeing patients as of April 14th and seeing a range of conditions that you can see in your handout before you. So for the sake of time, I won't name them all. General surgery, we have both Dr. Ali and now Dr. Mavrudis on board, and this program is live as of April 7th. And you can see the general surgical conditions that we are now able to provide care for below. Virtual care is increasingly important in a time when our patients may feel less ready to come in to our facilities. And so we are providing virtual care across a range of specialties and doing this in collaboration with community care as well. Moving on to emerging issues, there will be a full agenda item in closed session on this shortly, so I won't touch on that here. Moving on to outside and inside, this is, remember, a single item that looks at our community issues and our internal staff issues, and there's a full written backup on this, so I'm not going to touch a few items here. On outside, we have our third community conversation in Precinct 3 coming up on May 7th. In the Danny G. Macbeth Recreation Center. This is in Commissioner Ann Howard's district. We also have a new cohort of community health champions in Dove Springs. This is a Spanish cohort. One launched on April 24th and May 1st in the Austin Public Library Southeast Branch. And then we have a Del Valle Health and Wellness Center grand opening scheduled for June 7th from 10 a.m. to 2 p.m. Hope you all can make it to that. We moved that date up in response to feedback from a number of board managers and other feedback. Okay, on to topic 5, what we're solving for. These are areas that are not yet in operation, but that we're actively working on in production, or there's sort of a view into some of the inner works that we wanted to lift up to the board. So we have had a series of really productive conversations with Mobile Loaves and Fishes and foundation communities. Most recently, there is a one-page kind of synopsis in your backup of the problem we're trying to solve together. I won't go through that all in detail for the sake of time, but it is there. More than happy to follow up. Credit to Audrey Kwong and Lucas Bustelo and teams that putting that together. And this was very well received by Mobilos and Fish's partners. And as a next step, we have a walkthrough scheduled at Alan Graham's invitation to see their newest site, to think about the new neighborhood structure they're putting together, and ask the question, would it make sense for there to be a central health neighborhood, particularly for medically vulnerable folks coming out of respite, so that for folks for whom that is their desired housing arrangement works for them, to explore that together. So we're grateful to those partners, and it's an active development. I know that having good key performance indicator dashboards is of key interest to the board, and I wanted to provide the update that the first KPI dashboard should be rolling out next month with 5 metrics in the clinical and operations space. And then following up in June, we have a financial dashboard and a quality dashboard. So these are in production, and a lot of kudos to our data analytics and joint tech teams and operations teams for bringing these forward. Next is an organizational AI approach. So this was referenced actually during our community care presentation and even our driving forces presentation, but we are getting out ahead of this. We have a solicitation process that's coming close to the concluding phase to bring on a resource to help us look carefully at governance of our AI initiatives. You may recall that earlier I reported that we had done this sort of baseline readiness assessment. So this is that next step. What is the structure? And within that, to think about what are 3 to 5 use cases that will give us quick early wins that we can build on the central health environment. The board is aware that in the Sendero environment, we actually needed to solve for a doubling of expected volume and stood up a robust and highly operational AI call resource that has been well received by our customers there. So this is downstream of that. Fourth here is the enterprise biomedical engineering. As we grow and mature, we have a lot of connected devices in the Internet of Things, and it's important for us to actually have a dedicated resource to manage all the medical equipment that is connected or integrated with our environment. We had 2 of those new team members start at our new employee orientation, I believe actually earlier this week, so they're now on board. And finally, cybersecurity. So we are in the process of rolling out the egress platform, which provides visual alerts in every email coming in for things that might be suspicious or highly suspicious. So right in point of care, it flags you to pay attention. This might be a phishing attempt, for example. We also are actively tracking, and I believe in your backup there may be a visual to give you some sense of the, I think, literally millions or even billions of hits that we're getting on our system and how many are possibly squeaking through. I will take an opportunity to praise our joint tech team. We are very, very, very secure compared to other systems. So that has actually been validated recently by an outside group. We actually hired a group of hackers to try to get inside in what's called a penetration testing exercise. And they told us that it's been a long time since they were unable to get inside and create even a single vulnerability. And so we got a completely clean bill of health. That is not an easy achievement and is really important because it's now the case that health systems are actively under attack. So just a huge praise to our team. I'm going to get technical for a little moment, but I'm looking at my colleague, Manager Matwani. We're going to move to YubiKey. This is 3-factor authentication. Even if someone knows your password, unless they are physically present and put your finger on the YubiKey on your device, they cannot get in, right? So this is the current state of the art, and we are rolling that out shortly. So we're taking cybersecurity very seriously. And with that, I believe we have a mission moment. How am I doing on time?
Doing great.
All right. So mission moment. Over to our team.
While you're doing that, just thanks for the call out on cybersecurity or security in general.
I'm from East Austin. I went to Dell Medical School. I work in my neighborhood. I care for my patients at Central Health. I'm Brooke Wagon. I graduated with pre-med and like a degree in biology and Spanish in the 90s, and actually made the decision at that time not to go to medical school, even though all my peers at that time were going to medical school, because I wanted to take a break. For a long time, going to medical school was this thing that I held on to as this sort of thing that I would get back to. And then after 2 children, 4 miscarriages, and then the adoption of our last child from Ethiopia, when we were on the airplane home from Ethiopia with her, my husband almost died of an anaphylactic reaction. And I had a moment where I just let go. I finally let go of medicine as part of my identity. I said, well, this is a thing that I'm doing now. And 2 years after my daughter came home, there was the bond to open a med school in Austin. And I was a homeowner. I lived on the east side already. And I remember very clearly deciding to vote for the proposition. So I thought, well, it'd be awesome if Austin had a med school. And then I joked to a friend. I said, it wouldn't be awesome if I got to go there. But at that time, I also was really involved in my neighborhood. I drove Meals on Wheels, and I got to firsthand see what people go through when they are sort of on the edges of the healthcare system and don't have anyone to advocate for them. So when the med school finally opened, I was applying to be in that first class. I think if I had gone to medical school when I was in my 20s, I would have been worried about myself, thinking about myself. And going to med school when I did, I was very aware of what a gift it was to be there and what I wanted to do, which was to serve my neighbors. I started thinking about Central Health before it provided medical care, because my first primary care mentor, and I knew that I loved primary care, was Pete Zamora, or Guadalupe Zamora, who's on the board of governors for Central Health. He practices medicine probably 4 blocks from my house. I had taken my children to see him as a patient. Then when I was assigned a primary care preceptor at Del Med, it was Guadalupe Zamora. And I don't think that was chance either. I started working at Central Health in August of 2024, and it perfectly aligned with my vision for what I wanted to do with my new medical training. And the job that I have now did not exist when I started med school. It did not exist when I started residency, and it didn't exist when I started fellowship. But when I heard that Central Health was going to start doing specialty care, I wanted to do this. And of course, the pieces all fell into place. So it's the only job that I applied for because it was the perfect fit. So supportive and palliative care is a kind of medicine that provides an extra layer of support to patients and families going through hard things, whether that be for the patient or often for the patient and the family. We specialize in symptom management, but also in looking at the big picture. I often tell my patients that I'm the doctor that has time to step back with you and look at your life from a 10,000-foot view and say, what's going on and why does this matter? And how do I help?
Wonderful. So just want to mention this is actually part of a larger story in our newsroom. Want to shout out to Corey Mull, who wrote the feature, and our very own Edwin Evans, who shot and produced the video. And then I can't help but say, we are so fortunate to have physicians like Dr. Wagon and many others. We have the best physicians, nurses, clinical teams. It is such an honor. So it's the heartbeat of our work.
Okay, managers, I'm going to go on to item number 2. Receive and discuss updates on the CEO fiscal year 2025 review, including dashboard reports for the fiscal year 2025 budget resolution and fiscal year 2025 shared system priorities and key results. So, managers, just as a reminder, what we did is we voted on 2 documents. One of them was the CEO fiscal year 2025 review, which is the set of criteria and key results that Dr. Lee and his team are working on this year. So, and there's 2 parts to that. Well, there's 3 parts to it, but there's 2 parts in particular that relate to budget resolution, and then also to, as the first part. Second point is the shared system priorities and key results. So Dr. Lee is going to share with us an approach that he's has developed, which he shared with Dr. Brinson and I, for providing feedback to the full board on a regular basis on the progress that's being made on these key results. So he's not going to, because of time, he's not going to read every one of these. You all can read this on your own. But the point is that what he'd like to get from us is our feedback. Is this the type of matrix that's helpful to us in order to see regular progress on these key results and criteria. Let me also say that we have a different agenda item, a separate one, that we'll take in closed session after this that relates to the other part of the review that we voted on. So we're focused now with this item on the CEO fiscal year 2025 review. And I just want to say for myself that, Dr. Prince, I don't know if you want to add anything, that I am very appreciative of Dr. Lee with his team putting together this kind of stoplight report, I guess you could call it, because it's really going to give us a way to track and understand the progress that's being made on these key results. So with that said, I'm going to turn it over to Dr. Lee. And again, as I said, he's not going to read through every one of these because you have it and you can read it, and you'll have opportunity right now and also after this meeting if there's any feedback you want to provide. So you want to go ahead?
Thank you, Chair Kitchen, and thank you, Chair Kitchen and Vice Chair Brinson, for providing feedback along the way and helping us get to this tool. So as Chair Kitchen shared, you have this in front of you so you can see verbatim every board-directed budget key result and system objective key result. Those are produced verbatim in this document. So the process that will go into this document is that on a monthly basis, each of the owners of a key result is going to submit a status update and any key high-level update bullet points, of which you see examples here. Lucas, I believe, is the sort of keeper of the keys on this particular tool, so he'll chase folks down and get those updates. And our goal is to have all those updates in so that we can produce this backup version and get it to you by Friday before the Wednesday board meeting, because that's also a key goal. We may, I hope we're not over-promising, under-delivering on that goal, but we're going to try to get ahead of the schedule so that you can read it in advance and know what's coming. This is what the backup version will look like. There will also be a one-page, much more brief stoplight version that doesn't have all this detail in terms of the owner and the high-level update and the completion percentage and the numerical results. There'll be a one-page stoplight version that I will reference during my CEO update, that verbal review, and I might lift up a few of the high-level updates from the tracker, but I won't go through it in its entirety, but you will have it in its entirety. And then just to share with you, there are 2 points of tracker. It's in one stapled document, but actually the back 2 pages at the top say budget resolution tracker. So these relate to the budget key results that were directed by the board at the last meeting. And you can see some of these are quantitative. So for example, under expand access to specialty care, that's at the core of our healthcare equity plan, and the target this year is 13,500 visits. You can see that we have 7,135 as of March, or 52.8% of the goal as of the end of March, halfway through. So we are on target. We're green to exceed that 100% target. Going down to the care coordination goal, the goal is 1,400 episodes of care in the year. We are 803, you can see the breakdown there, or 57% as of March. So where we have numerical targets, we will try and put numerical results here so that you can see it in the drill down. And again, I'll hit it at a high level in the verbal during the CEO update, and we can always engage with any questions that you may have. on an ongoing basis. So that is the intent. Happy to get your feedback and welcome your recommendations.
Okay, so our goal right now, and I'll start on this side and go around, is to provide feedback to Dr. Lee on this tool. Is it helpful to you? Would you like to see anything different about the tool? Obviously, you haven't had time to read the detail, but we're not here to talk about the content of the key result at this point. We're here to talk about the tool so that we can give Dr. Lee feedback on whether this is the right tool for us to use. So I'm going to start with Manager May. Do you have any comments at this point?
I have to obviously look like everybody else. I've got to look through it, but my first thought is that it just seems very busy. Like it's there's a lot there, and I've got to sift through it. I'm sure as I look through it, it won't seem as busy, but that's my first thought. My second thought, and I don't know, I know that a lot of these you've got the owner, like who's going to deliver and at what level, et cetera, on some of these projects. And it's good to know that, but at the same time, as we move forward, I want to make sure that there's a way that we understand that at the end of the day, it comes back to your leadership and to your work, right? So that I'll leave it at that.
Do you want to talk about the one pager you're going to do, which we don't have in front of us
Yes,
now, but
and
that
in
might
fact,
help with your first comment. That might help with your first thought, Elisa.
Okay.
Is it in here?
It's not here, but I think, Dr. Lee, I think that you had mentioned that.
Oh, yeah.
Oh, is
Okay.
is it on here?
It should be fiscal year, or the key priorities and results pool, and then the one pager.
Okay.
Then the budget resolution and the one pager.
Yeah, so my
Oh, I see it.
oh yeah, so this is actually two versions of the same. So this is the one pager, which is what might go in the verbal updates you update. This is the deeper backup that includes the numbers and the high level updates. That goes to 3 pages. So I don't know if that's helpful. Maybe we shouldn't have stapled them all together like that, but you have the example of the single page version and then the 3-page version for the results.
Okay.
Is that helpful?
Yeah,
Yeah.
it's helpful. And then, do you want to speak to Manager May's second comment?
Yes, and so Manager May, absolutely, as the as a CEO following the directive of the board, I have accountability for all these objectives. This relates back to the presentations we've had previously around the management system. So at executive level, we break the objectives into key results. Each of the owners here is actually working with their teams to break their key result into a set of key results at, say, the second level. And in some cases, those second level owners break it further into a third level key result. And this is the first main pillar, if you will, of our proposed management system. We've seen at the committee conversations that video about how Toyota leads and manages, why we hired Kim Heinen. So this is pillar 1, is to cascade the board strategy through specific actionable operational steps all the way through the organization. Just to kind of mention briefly, that will then link to pillar 2, which is the daily management system. Folks who are doing their work every day, whether in eligibility, on the clinical systems, in finances, what are they tracking every day, and how does that link all the way up to board-directed priorities through this system? And then pillar 3, which is actually what the board looked at last time, is that those horizontal cross-functional streams, those green squiggly lines, and the notion that there's some sort of chief engineer or a horizontal leader who's connecting the dots around the patient journeys or around the things that go across this system. So those are the 3 components of the management system that we're building, and all of which I'm responsible for, but obviously there's thousands of folks carrying out that work in a way that you can see how all that work rolls up to our specialty visits being on track, for example. So you can see at the summation level, are we accomplishing the goals?
Where you have the 25, like on the completion date, 25% of that.
Yep.
Or
Yes, so then imagine that to deliver, let's take that first one. I believe you're referring to the new employee orientation key result. So you can see here that the goal is to deliver a system-wide new employee orientation result by the end of FY 2025. The high-level update says that we have a framework and we're engaging the key stakeholders from all organizations for feedback. So Jeannie's estimate is that is about 25% of the way toward delivering the overall goal of actually having this orientation occur before the end of the fiscal year. So that one's a little bit fuzzier because it's not so quantitative, but that's her estimate of how far down the path she is to complete the result.
Okay. Okay. And again, this is y'all's first impression. There'll be opportunities as you get a chance to really dive into it to provide additional comments for Dr. Lee if you have any more. Okay, Manager Jones?
I agree with my colleague here, is that this is sort of, it provides information, it's just sort of busy. And I think to the degree that if we could do, or at least the way I think is sort of in a analytical point, up and down. So column 1 would be the foster an exceptional shared culture. Then high level updates. Then completion date. And then who's the owner of that? So what it is that we're trying to get at, what is the measure of that we're trying to get, what is the time frame, and then who's ultimately responsible. So if I'm looking at this, I can go through all of this and say, okay, this person is responsible. That's just to me. I mean, each of these are going to be different, but I would suggest that because this right here is sort of busy to be looking at and making evaluation. Those are my comments.
Okay. Manager Motwani?
Yeah, I recognize the profundity of it. I also recognize the profundity of the work. Appreciate the one-pager. Definitely appreciate, I think it's really salient, the explanation of the pillars, particularly the dimensions, and how, well, the first of which of how it cascades across the whole organization. The reason I'm really happy that we're moving toward a more, I think, professional and sort of modern class objective and key result tracking mechanism is because mission creep is a problem for everybody, all organizations, in a world where our attention spans are shorter than ever and our demands are higher than ever, and demands on our attention are higher than ever, and on our time are higher than ever, and our time is shorter than ever, and we're being pulled in many directions. And so when you have one mission that goes into key objectives that cascade across the whole organization such that every single person is able to triangulate where they are in the constellation of the work we're doing and how we're moving that mission forward, it does get a little complicated. And to me, that's what I signed up for. So I'm glad to be able to see it. But I also do appreciate the simplicity of the one-pager. And so, yeah, I'm thankful that we're moving in this direction. I do need to sit with it. I'm sorry if it was in the backup. I didn't review it.
No,
okay,
it wasn't.
yeah, and so I'll sit with it a little bit more. But thank you.
Okay. I'm hearing everyone say they need to sit with it, which is fine. This is just initial impressions for Dr. Lee. Go ahead.
Thank you. I think what would be helpful for us the color coding. So to me, it should be red, yellow, green. Because that would make it very clear to where the status is, and it wouldn't be as busy. We know which areas are lacking behind. So a simple color code, because green to me means it's complete. So I think that may help my other board members to decipher this information, because that's my comment for that. Thank
That's
you.
great. I had the same comment, Dr. Mensaitive, actually, as we were doing. So there'll be some kind of key that says green means we are on track to complete the goal by the targeted date. So if the date is by the end of the fiscal year, are we on, and we're 50% through the year, are we doing 50% through the goal? We could do it differently, in which case things might be red all year until we get to the final lap. But it might be, I think it might be more helpful for the board to know, are we on track? And so that's what green would represent. But we'll define that. And then my feedback to Lucas was, if it's all green, we're probably doing this wrong. There should be some yellow and some red, because it's not all green. But this is the very first, well, the idea is if we're yellow, this thing would turn yellow, right? And so it just happens to be that this first version, there's only green. But I think areas that we didn't get to, like this one should be yellow, because we haven't really gotten data yet on it, right? And so in the future version, if we're not on track, it will be at least yellow. And then if there are significant concerns that we're going to miss our target, it will be red. And so that would be the general goal.
So that's what I'm saying. Maybe you need another column. Are you on track, yes or no, and the color.
Oh, this column on the far right would be green, yellow, or red. There shouldn't be any white.
He's gonna make this column.
Yeah.
Yeah.
Gonna replace all green.
Yeah, exactly. No, but I think what he was pointing to, if it's green, also means that they're on track at a certain time. Correct? That's what I understood.
Yeah, I think what he's talking about doing, you may be talking, you could have two color-coded columns. One if it's completed, one if it's on track, but that's probably unduly complicated. So I think we're hearing you that you'll get the color coding down. Okay.
Well, I got to see it earlier.
Yes.
So, I'm kind of cheating, but I like it a lot. I think it's concise. I think I know what he's talking about.
Microphone.
Okay. Well, anyway, I think it's concise, and I think it's just a quick update that can take us 5 minutes instead of taking us 50 minutes.
Yeah.
And then any particular thing that stands out, I mean, you'd want to review this before the meeting so that you could say, well, this kind of stood out to me, but I think we'll all get used to it.
Okay. Manager Valadez?
Just off the top of my head, because I'm the one that suggested these two, an increase of more than 5% of MAP and MAP basic enrollment, and that's still here. That is not what I said. I said 15 to 20%.
Manager Valdez, let me remind you, what's here is what we voted on. We addressed your concern by adding.
I'm sorry, I didn't realize it. I'm sorry, I apologize. I didn't
That's
realize
okay,
y'all
but
had not
your thought-
accepted it.
We captured your thought a different way, and it's in here. But Dr. Lee, it's more. It's to. You had language about analyzing what it would take for us to up our game in terms of enrolling more people. So that language is written in the first column, but I noticed, it's one thing I noticed, Dr. Lee, there's no comment on completion to date on that particular aspect of the item, so that's probably what you're noting here, Manager Valadez.
I appreciate your comments, Ann, but this is my time. And I did not realize that we weren't accepting the 15 to 20%. I'm sorry, it's my fault. I didn't realize that.
Okay.
And so I'm just saying that, especially when I think in the following meeting, we were told that we had increased MAP membership by what, 12%, 12.7%, something like that. And so if we're going to keep it at 5%, it to me was not, yeah, there's no gains as far as I'm concerned. And that is what we were supposed to be accomplishing. We're supposed to be accomplishing eliminating the uninsured and underinsured population in Travis County, providing services by MAP and MAP Basic, and that's first.
Okay.
Not last. So
Okay.
I'm just saying that. And the other suggestion I made was to see improvements in demographics of your mid management up.
That's in here.
And I saw demographic, provide a leadership demographic report and termination report. I didn't see where we were increasing the number and the change in positions.
Why don't we do this?
I'm just saying that those are my comments.
Okay,
Thank you.
that's fine.
Yeah, and
That's
so,
fine.
thank you for the comments, Manager Valdez. Actually, and I apologize. We bundled all these packets together, so it's hard to track, but there's the one-page version of the budget resolution, and then there's the longer with the high-level updates. So if you go to, this is Objective 3, Member Enrollment Engagement, Key Result 1, Enrollment Eligibility, you can see some of the breakout here. But actually, as we got these data, it turns out that we are 11.4% over FY '24. We are way ahead of where we thought we would be. And if we continue at this rate, which we might not, because remember, to enroll in MAP, you have to provide all the information that you might not feel safe doing so. But if we stay on trend, we would end up with 97,000 or so folks enrolled. So we are on track.
Achievable.
Now, there's a second part of that goal, which is specifically around homeless individuals. You can see here that we are, at 8,500 out of a goal of 11,400. So you can see we're 74% of the way there. We've got, a number of months left in the fiscal year. What we need to add is an update on that complete analysis of resource and other factors impacting the capacity to increase enrollment, consider approach to expand capacity. So that was the language that we captured. We have not provided this time I think something Manager Jones said earlier, this is our first time doing this. It's not complete yet, but we'll make sure that there is a high-level update point and perhaps maybe break out completion to date, for that as an individual component of this.
So then maybe my concerns or the inability to see the concise and specific improvements occur might go to the format.
Yeah, totally
What we
fair.
do.
I think we can try and
Okay.
clean this up and make it easier to see. And maybe Dr. Benson's point also is that as it's consistent and we get used to where the information is, sort of like our financial statement, like the first time you look at that thing. Yeah, you learn how to read it. So we're going to try and make it relatively consistent so that we stabilize. And then to your other point that goes, I know, I've been living with this stuff. So that goes to empower and develop our team. Key objective 4 on the system priorities and key results. Key result 5, provide leadership demographic report and termination report. You can see on the detailed version that Jeannie has actually completed the termination report. I'm not sure if we had it, but we meant to deliver. I'm so sorry. So so we're doing things in sequence with our chair and vice chair. So that particular report is prepared. We will bring it to our next chair, vice chair weekly touch point, and from there throughout out of the board. So we're working on it. Yeah.
And when I spoke with respect to my additions, I was also speaking in terms of making sure that we had complete evaluation, exit evaluations from all those leaving our employ, so that we can get a true picture as to whether or not we may or may not have a culture problem.
Okay.
Thank you.
Okay.
The one comment I have is well, actually two. One in my head, I'm like, it would be helpful to have a legend or key about what all these mean, because to Manager May's point, like just getting a sense of how to read the document. Because I think just given my past experience, when I look at things, I'm looking at like, what's the strategy, where's the goal, what are the tactics, who's responsible for implementation. And I haven't read through these, but I can tell like there's one in particular here that this is an example where the goal is included with the tactic in the same box, and it's sort of just for me, just the way I look at things. And so I'm looking forward to learning how to read the approach that you're taking. But I appreciate it very much because it's a good way of cascading this down to the most frontline employees so they understand their responsibility.
I have one thought, and actually I don't know if it works for everyone or not, but it is hard to read. I mean, it's a great tool, and we'll get used to reading it, but it is a lot. And so, to me, the color coding is important for the one-pager and not as important for me in the detail. So, but that may be different for others. So you might play around with, in your detail one, maybe you take out that column so that your one-pager is where you see the colors, the red, yellow, green. Because it just, the colors are distracting to me in the detail. Just a thought, so.
And the one page should be presented on the top.
On the top, yes.
Yes,
So,
because otherwise we don't think we got it.
that's right. Okay, any more feedback for
At
Dr.
the risk of opening a can of worms on the color notion, you know, the color could just be the backfill. Just a really light highlight green or yellow, so you don't have to have a column for it.
Yeah, great suggestion.
That's an idea.
Yeah.
That's a good idea.
Well,
Thank
Very
you,
nice.
thank you.
Okay, so we're gonna make this less busy. We're gonna play with the backfill. We're gonna have a key that explains what the color is meant to signify. And then we'll keep iterating, right? And then once we're stable, then we'll get used to it. It'll be easier to read. But really appreciate the feedback. Really appreciate the guidance to get here.
Okay.
And hopefully this helps connect from, this really important work the board did to say these are the negotiated focus points, and then this is how we cascade through, actually get the work done, and give you feedback on where we are.
Okay. Any other comments? Go ahead.
So when we're receiving this, are we receiving it on a Word document, or how are we getting this information? And is this accessible somewhere to the public? For instance, if we're having this as a public meeting?
It will, the target, and let me know if you want to change this, but in the Friday backup before the Wednesday board meeting, that may be May 23rd or whatever it is, we'll try to get the detailed version to you all with the backup packets. And they will be in the backup for the public to see as well. So that's the intent. We heard the board last time in terms of thinking about, can we go digital for some of this to avoid killing as many trees? So we are in process in exploring that question as well. So hopefully we can combine some of those things.
Okay, go ahead.
In addition, that will go, Dr. Lee, to the concern that some of us have had historically for years, that we don't get our full backups on Friday. We get them sometimes, oftentimes, right before the meeting or during the meeting. Thank you. And that would be an improvement for you, sir, and your administration or your staff. Thank you.
Okay, I'm going to move us on. Oh, go ahead.
I mentioned several times the possibility of providing tablets or things that we could have easier access as opposed to just having these documents available. So I would encourage you to look at the opportunity for board members, not personal use, it's for here, the meetings that we come to. And so I would encourage us to consider that option there.
Yes, absolutely. We hear you loud and clear, and we're actually in process of exploring that further. Absolutely.
Okay, I'm going to move us on to the next item, which is in closed session. So let me read that. Let's see. We are going to go into closed session for items 3 through 8. I'm going to read those. Item 3 is discuss and take appropriate action on the performance of the Central Health President and CEO, including activities and performance criteria for the upcoming year. Number 4 is receive an update from council and discuss the impact of certain state and federal policies. Number 5 is discuss and take appropriate action on a proposal regarding a future state central health system organizational chart and high-level integrated system concept. Item number 6 is discuss update on matters related to a performance review by Mazars USA contracted by Travis County. Item number 7 is receive and discuss a briefing regarding Travis County Healthcare District DBA Central Health versus Ascension. And we will take item 7 last. Item number 8 is to receive and discuss a briefing regarding the Birch lawsuit. I'm sorry, David, I'm shortening. and that's it. Okay, so I announce that the board is convening in closed session to discuss agenda item number 3 under Texas Government Code Section 551.074, personnel matters, and under Texas Government Code Section 551.071, consultation with attorney. Agenda items 4, 6, 7, and 8 under Texas Government Code Section 551.071, consultation with attorney. And agenda item number 5 under Texas Government Code Section 551.074, personnel matters. Under Texas Government Code Section 551.071, consultation with attorney. And under Texas Government Code Section 551.085, governing board of certain providers of healthcare services. Okay, we're gonna move now into closed session. Today is the 23rd of April, it is 7:01. Now, members, it takes us a few minutes to go into close, so we have a cake in the other room to celebrate a wedding that's coming up on Friday. So if we want to move in there and take this time while it takes to transition to have some cake. And we will start back up at 7:10. I think we'll just be fast on the cake.
We can also do a unanimous happy birthday to.
Yes. Would you like to lead that?
I'll sing you Las Mañanitas.
Okay. Okay, does anybody want to sing or lead? Happy birthday to you. Happy birthday.
Recording in progress.
It's April 23rd, the time is 8:34, and we're entering open session. So managers, we're moving on to the last item, which is confirm the next regular board meeting date, time, and location, which will be scheduled for Wednesday, May 28th at 4 p.m. This time I'm ready to accept a motion for adjournment from Manager Valadez, a second from Manager Brinson. All in favor? Aye. We are adjourned. Thank you all. Good night. Good night.